early in the morning. Okay, it's actually 4 a.m. But I know it's afternoon for you folks, and we're going to have a very productive session today. We're going to be talking about life in the United States. We'll be talking about substance abuse, human sexuality. So let's get started. Good morning, everybody. I see you all saying hello. Good morning. I hope that everybody can see me okay. Can you all see me okay? Yes, great. And everybody can hear okay? Terrific. Okay. Today we're going to start off by talking about family life in the United States. And as I mentioned yesterday, this part of the USMLE can be particularly difficult for students who did not grow up in the United States. So these are just some things that are very characteristic of the United States culture. And unfortunately, the first thing that we talk about in the United States culture is divorce, because divorce is unfortunately common in this country. Okay. About half of all marriages will end in divorce. My TAs, can I have my pointer, please? Okay, I'm looking for the pointer. And there it is. Okay, thank you. Okay, so in the U.S., the divorce rate has been rising steadily. About, as I said, half of all marriages. We have the highest divorce rate in the United States. And what's important for USMLE with respect to this is that people who are divorced are at higher risk for illness, both physical illness and mental illness. People with strong social support systems do better generally with respect to health in all areas. People of similar backgrounds, as you know, have a better chance of success with marriage, and people who marry young also have a very high divorce rate. Let's take a look at this question. Get your clickers ready to click in on the right answer. This was a board question, as are all the questions that I put up. A 26-year-old man and a 29-year-old woman get married after a 2-year engagement. They're both Episcopalian and are both from middle-class families. Both sets of their parents are divorced. Which of the following factors puts this couple at highest risk for divorce? Their ages, the length of their engagement, the parents' marital histories, socioeconomic backgrounds, or their religious backgrounds. Okay, my friends, we're going to put a counter on for 30 seconds, TAs. Okay, can we put our counter on? The clock? Okay. Excellent. Okay, I see some of you clicking in. Okay. That's great. Thank you. No, I think the second, move it over. I think you need to move the timer back to the Q&A box. That's it. That's a good spot for it. Open it up. If you can open up the timer. Good. Thank you. That's good. Yeah, I need it on the screen. Very good. Okay, my friends, time's up. And the right answer is C, their parents' marital histories. And 65% of you got it right. All of a sudden it became 75%. I don't know what happened there. Okay. Marital histories. Children of divorce have a much higher likelihood of divorce. Okay. Okay. So people who are divorced have a high rate of hospitalization for mental disorders. It's not clear which comes first. That is, the mental disorder leads to the hospitalization, leads to the divorce rather, or the divorce leads to the hospitalization. So it is not clear, but there is an association there. And children of divorce are more likely to have behavior problems and emotional problems. And this is an interesting factoid, I thought. And you may see this somewhere, because people who never have children are more happily married than people with children. Children are a strain on marriage, okay? And those of you with children know what I'm talking about, okay? Okay. Okay, let's talk a little bit more about life in the United States. Um, it Socioeconomic status is a term that has to do with your occupation and your education. Although income is not directly determines socioeconomic status, it is correlated with it. And in the United States, physicians of all the professions, have the highest socioeconomic status. If you had to guess at what the average income in U.S. dollars is I don't know if that's easy for you guys or not so easy, but what do you think the average income in U.S. dollars is for an American physician? I'm looking at the public chat. I'm looking for your responses. What do you think it is? Okay, this is in U.S. dollars. Well, we're going up. We started at 40,000, Ibrahim, and Mohammed says 150,000. Ahmed says, whoa, 200 to 300,000 per annum, yes, per year. The answer is about $200,000 per year. And that includes all of the specialties. Some of the specialties are much more highly paid in the U.S. Neurosurgery, people out of their residency start very often at $400,000 or $450,000 a year. Pediatrics and psychiatry, family practice are the lower paying specialties, under $200,000 a year. So the surgical specialties make the most, but the surgical specialties also pay a lot in the U.S. In malpractice insurance, that is, if you're sued by a patient, the insurance company has to pay. And malpractice insurance for surgeons can approach $100,000 a year. Okay, so it's really how much you keep, not so much how much you make. That's important. Okay, let's take a look at this board question. Which of the following living situations is least common in the United States? A 34-year-old resident living with his parents, a 46-year-old divorced man living with his son, a 65-year-old man living alone, a 46-year-old single man living alone, or a 46-year-old man living with his wife. Okay, let's put our timer on. And my friends, I'd like you to answer that question. Which is least common in the U.S.? I'm looking for you to click in on the answer poll. Very good. Okay. Least common in the United States is, and most of you got it right, 91%, a 34-year-old medical resident living with his parents. In the United States, you're expected to be independent at as young an age as possible and for as long as possible. And whereas in some countries, an old person living alone would be considered shameful for the family, in the United States, we are very proud of old people living alone and taking care of themselves and even still driving a car. Okay, sometimes that's not so good. But that the idea of being independent until you conveniently die of old age is a good plan for most people. So a 65-year-old man living alone is very common, or 65-year-old woman even more common, since women live longer than men. There are many men who are raising their children after divorce, so this is not uncommon. The man living with his 10-year-old son. But the medical resident should be on his own by now. Okay. Okay, anybody know who this is? Who is this gentleman? My friends, Bill. Yes, it is Bill. That is the head of Microsoft. That's right, Bill Gates. He is in a very high socioeconomic group. He's one of the richest men in the world. And there is a positive correlation between socioeconomic status, good health, mental health, satisfaction in life, freedom from illness, and life expectancy. This is not a big surprise. Okay. Oh, here we have another board question. What percentage of American households consist of a father who works outside the home, mother who does not work outside the home, and a few children. So this is what we would call the traditional family. Father is working, the mother is home with the children. Okay, what percentage? Okay, very good. Well, let's see. 47% of you got it right. It's between 15 and 20%. It is the minority of American families, which are traditional. Most American families have two working parents. Okay, so 15 to 20% only have the traditional situation where the father works and the mother stays home. Here's the next happy topic of life in the United States, and that is suicide. Now, luckily, fortunately, the United States does not have the highest suicide rate in the world. There are quite a number of countries that are above us. The Scandinavian countries, for example, it may be all those dark days in the winter. Japan has a higher suicide rate than the United States. So we're kind of in the middle with respect to developed countries. This is a picture of a person who committed suicide at the age of 27. And he was quite a famous person. His name is Kurt Cobain. And I show his picture to show that even people who are very successful may commit suicide. Okay, so it isn't just that you haven't had any success in your life. There are many factors that contribute to suicide. Okay. In the United States, as you know, guns are legal. It is legal to carry a gun on your person with a permit. And guns are the most common cause of death in the United States. Men are much more likely to actually kill themselves, although women make more suicide attempts. That is because men tend to use guns and fast cars and more violent means, okay, than women do. Adolescent suicide is unfortunately common in the United States. It's the third leading cause of death among adolescents in this age group. The leading cause of death among adolescents is accidents, in cars particularly. The second leading cause of death is homicide. Okay. So adolescents have a relatively high rate of suicide compared to other age groups. And the group with the highest suicide rate are the Native Americans. And I mentioned them yesterday, that there are approximately 3 million Native Americans in the United States, making up about 1% of the population. Those are the people that were in North America when the Europeans discovered, quote unquote, North America. Okay. So they have a very high suicide rate. The reasons are related to the fact that they are what we call disenfranchised. That is, they have lost a lot of their land. They're relatively poorer people, and they have a very high rate of alcoholism. Okay, so those things contribute to the high suicide rate among Native Americans, adolescents and adults as well. Here are some of the rates in the United States of suicide. The suicide rate has increased, but not very much. There are a number of reasons why suicide rates may have increased in adolescents. Bullying, including cyberbullying, where teenagers threaten each other, etc., over the internet. Expectations that teens act more like adults. Now, many people have thought of suicide in their lifetime. The thinking of suicide, called suicidal ideation, at least 54% of the population have thought at some time about suicide. And many teenagers had a friend who committed suicide. And in teenagers, as you know, they tend to do what the other teenagers do. And if they are depressed, if they have serious family problems, suicide is an unfortunate option for teenagers, particularly if they are depressed and or if they drink heavily or use drugs. So the management of suicidality in teenagers is to ask them about it, especially if you know that another teenager in the neighborhood has committed suicide, and address the substance abuse or mental illness problem, often major depression. Okay. Unfortunately, in the United States, suicide is also more common in the elderly. And that is, in every country, suicide is a bit more common in teenagers. But in this country, the elderly have a very high suicide rate. And that's very bad statistic and very shameful kind of statistic. In the United States, being old really doesn't have anything good going for it. In many countries, an elderly person is respected, highly respected, and taken care of by family members. In the United States, as I said before, the ideal is to be independent for as long as you can, independent until you die of old age, and that, of course, is unrealistic for many people. So elderly people have lost not only their status in society, but they've also lost their health, their loved ones, their friends to death. So the losses are quite extensive. And old white men have the highest rate of suicide of any other group in the United States. Okay. Most people who commit suicide will tell someone about their thoughts. Very often it is the primary care doctor. So you, as a primary care doctor, are the one who's going to be able to identify the suicidal patient and save their life. Okay. What people do when they are depressed is they very often have lots of physical symptoms. And they will go to their primary care doctor with complaints like headaches, problems sleeping, anxiety, for medication. So you may be the first person that can identify the suicidal patient. When a patient say things, and these are some of the things that they've had on the boards that a person will say when they are suicidal. They will say things like, my family would be better off without me. Now you can ignore a statement like that, or you can say something in response. And the ideal is to say something in response. People sometimes say that, Mr. Smith, but could you tell me, please, what you mean by that? Have you thought about harming yourself? We ask people directly, okay? Because we can save lives this way. And we have medications and we have interventions that can do that. But first, we have to know that the patient is feeling this way, okay? Somebody's asking, do you have to memorize percentages for the boards? The answer is no. You have to know, is it low, medium, or high? So when we talked about the number of families that are traditional families, we would say, since we know it's 15 to 20%, we would say it's relatively low compared to both parents working families, which is about 50%. So you don't need to know the difference between 10 and 20%, but you do know to know when it's low, when it's high, or when it's in the middle. Okay, my friends? Okay, Saleh? Okay, so you don't have to memorize those numbers. Okay, people who, you're welcome. People who have been in mental hospitals have a higher rate of suicide. That is, people with mental illnesses have a higher rate of suicide. 15% of depressed people will ultimately kill themselves. 15% of alcoholics. 10% of people with schizophrenia. 5% of people with a borderline personality disorder. Borderline personality disorder is characterized by being very impulsive and doing things on the spur of the moment. And if they feel badly about something in their life, they may make a suicide attempt. So they also have a high suicide rate. This is an interesting fact, and that is that identical twins are more likely to both commit suicide than non-identical twins. And that indicates a genetic component for suicidality. And certainly all of these disorders have a genetic component. to them. And we'll be talking more about that. Okay. This is a very sad fact in the U.S. Doctors have a higher suicide rate than the rest of the population. And it isn't only doctors, it's doctors and dentists and veterinarians, okay? And this is a really sad comment here, that psychiatrists have the highest suicide rate, okay? It may be that people go into psychiatry because they're interested in their own personal difficulties. It may be that listening to people talk about killing themselves all day long becomes pretty depressing, okay? So it's not clear, but psychiatrists seem to have a particularly high rate. Female doctors in the United States have a much higher suicide rate than do other women. So does anyone want to take a guess as to why physicians, dentists, and veterinarians have such a high suicide rate, my friends? I'm going to look at your chat box. Stress, Abraham thinks stress. Well, there's a lot of stressful professions. Yes, it is a stressful life. Too much work, very hard life. Think of something a little more practical. What does the physicians have access to that other people don't have? Dentists have access, and so do veterinarians. Drugs is right. That is correct. Not so much drug abuse as the fact that there's, yes, Ahmed, right, that there is the availability of drugs. Exactly right. That it is, a physician can write a prescription for a barbiturate, which kills you pretty fast and easy. Okay, you don't have to think about jumping off a roof or killing yourself with a gun or anything painful. Okay, so when there is a means, yes, they know how to die quickly and efficiently. That is correct. And that's probably why female physicians have a higher suicide rate, because these means are very efficient. Okay. Okay, so professions with access to prescription drugs. Suicide is associated with low serotonin levels. We know that serotonin is very closely associated with mood, but serotonin is also very closely associated with impulse control. And people with poor impulse control are more likely to commit suicide. So low serotonin is associated with depression, it's associated with anxiety, and it's associated with impulsivity. Okay. Okay. Police, why are policemen more likely to kill themselves in the United States? Anybody think of why? If you know that police in the United States, that is right, Ahmed, that is right. They have a gun and they know how to use it, okay? So if they use their gun, they are definitely going to kill themselves. Most people really don't know how to manage guns. Okay, so police do have a higher suicide rate. Lawyers have a higher suicide rate in the United States. But there are so many lawyers who are always very busy suing doctors that what we say here is, why do lawyers kill themselves? And then we say, who cares? That's terrible, isn't it? Okay. Too many lawyers. Our religion is protective. People who are religious are less likely to kill themselves. Okay. Particularly certain religions. As you know, in the Muslim religion and the Catholic religion, those religions basically prohibit suicide by saying that the afterlife will be very bad for people who commit suicide. The other religions do not focus on the afterlife as much, okay? So there are lower suicide rates in the Catholic and the Muslim populations in the U.S. Okay, so here are the risk factors associated with suicide, and of course the highest risk factor is having made a previous attempt. That is the highest risk factor, and the more recent the attempt, the higher the risk. So people who have attempted suicide within the last few weeks are at much higher risk than those who have made an attempt a few years ago. Okay, so a recent suicide attempt has the highest rate, okay, risk. Old white men, people who are not in a long-term relationship, unemployed, they're not gainfully employed or retired, living alone, poor health, having a mental disorder, etc. The others are less important, okay? The old white men who live alone, who are in poor health, are the ones who are at highest risk. Okay, so the single best predictor of suicide is a suicide attempt. Okay. When we interview a patient and we try to determine if they are suicidal, we look for whether or not they have a plan of how they're going to kill themselves, and do they have a means of suicide. If somebody has just gone out and bought a gun or is accumulating pills, we would say that that is a plan and a means. We recommend to the patient that they go into the hospital immediately if they have a plan or a means, and if they refuse, we can hospitalize them against their will. In the United States, if somebody is suicidal or a danger to someone else, so a danger to oneself or others, can be hospitalized for a period of time against their will. Most states in the United States will allow hospitalization for 24 hours. Many states allow 48, even some 72 hours without any court intervention. Okay, so a doctor, by his or her judgment, can say that a patient is suicidal and hold them in the hospital against their will. There is security in hospitals. The doctor, him or herself, is not the person that is holding the patient in the hospital. It is the security system of the hospital. Okay, my friends. Okay, so if somebody is suicidal, we hospitalize them. And as I said, we can hold them for a few days. Now, if we think the patient needs longer hospitalization, we have to appeal to the court system. The court system will decide whether or not that person should be put in a longer term type of setting for their own safety. Okay. People who are hospitalized because they are suicidal retain all of their civil rights, okay, except for the right to come and go, and of course the right to kill themselves, okay. So very often we will hospitalize patients who are suicidal on a locked inpatient unit in our hospital in Newark. And the person cannot, in the United States, as you know, you cannot just put somebody in a locked situation and throw away the key, okay? Every Wednesday, the judge from the court in Newark sits in the inpatient unit at University Hospital, at our hospital, and talks to the patient. Patients bring cases to him when they want to be released. Okay, so people who are put in against their will provide a case for why they want to be released. So they have the right to be heard by a judge, and they have the right to have a court-appointed lawyer for free, help them if they believe that they need to be taken, get out of the hospital, and the judge will decide. Okay. Okay. Now, when people are very depressed, and we'll be talking quite a lot about major depressive disorder. Depression, let me just say that depression is a term that's thrown around very loosely. That is, sometimes we'll say something like, oh, I'm so depressed, I missed a TV show that I like, okay? That's not depression, as you know. Depression is a serious, dangerous medical illness, okay? People who are depressed are in danger not only of suicide, they're also in danger of not caring for themselves. They're in danger of getting into accidents because they're not careful. They have they're in danger of losing their jobs and their relationships because of depression. Okay. Now, when somebody is extremely depressed, they are very slow-moving typically and very fuzzy thinking. They don't think clearly. They don't sleep well. They're very, very exhausted, although they cannot really sleep well. And they cannot think really clearly. So although they may be very depressed and not want to live anymore, when they're extremely depressed, they cannot really conceive of a way to get out of this life, to kill themselves. So when we give people an antidepressant, and of course, unfortunately, antidepressants take about 3 weeks to work to relieve depression. The antidepressants, though, do relieve the problems thinking fairly quickly. So now you have a patient who is just as depressed as they were before, but now they're thinking more clearly and they can plan and buy the means for a suicide attempt. So that's why we watch patients very closely when they first coming out of a depressive episode, because there is an increased risk for suicide at that time. Okay. People who have chronic pain or chronic illnesses also are at higher risk for suicide. Okay. Okay, let's talk a little bit about healthcare utilization in the United States. First of all, the United States is one of the few developed countries in the world that does not have socialized medicine. Socialized medicine is a system by which tax dollars pay for medical care for everyone. Okay? And most developed countries have that system. That is England and Canada, Australia, Germany, Spain, France, all have socialized medicine. In the United States, we don't have that. In the United States, every individual is responsible for their own healthcare costs. There are 2 groups in the United States which are subsidized with respect to their health costs by the government. One group is the elderly. People who are 65 in the United States automatically become eligible for a system called Medicare. Medicare is funded by the federal government and takes care of healthcare needs of the elderly. And 65 is the cutoff point for Medicare. That is when you become elderly in the United States, at 65. The other group that have healthcare provided by government funds are the extremely poorest people, and they are covered by a system called Medicaid. So it's aid for the poor, care for the old. Care for the old, aid for the poor. Medicare for the old, Medicaid for the poor. Okay. You have to be extremely poor in the United States to qualify for Medicaid. You essentially have to have no assets and no steady income. Only then will you qualify for Medicaid. So we have lots and lots of people in the United States, what we call the working poor, people who have jobs but cannot afford to buy health insurance. And health insurance for a family of 4 costs approximately $1,000 per month. That's a lot of money. But health care is even more expensive. One day in the hospital in the United States is $1,000 without any treatment at all. Just to be in the hospital for one day is approximately $1,000 a day. Okay, so Hind is asking why. That's a question that you would that's a question on everybody's lips. But hospitalization is extremely expensive, and particularly for the personnel that staff a hospital, it's very expensive. Well, we've already talked about the salaries of doctors in the United States, and other staff, of course, are required. Okay, so it's quite an expensive proposition. If you don't have any money at all and no assets, and you get sick in the United States, and hospitals by law must take care of you. If you come to the door of a hospital emergency room, by federal law, you must be stabilized. So hospital cannot turn away a person who cannot pay. Private doctors can turn away people who cannot pay. And before a doctor accepts a patient, he or she finds out whether the patient has health insurance. If they have health insurance, the doctor will accept the person as a patient, or if the patient pays up front. So poorer people don't go to private doctors' offices. They tend to go to hospital emergency rooms, even if they're not very sick, because the hospital, by law, as I said, must stabilize you. Hiba is asking, how about doctors? Do they also have to pay for health insurance? Absolutely. Absolutely. Now, very often health insurance is paid for by the employer, with some addition by the employee. So the employer very often pays the majority of the health care insurance costs, but the employee more and more now is having to pay a good portion of health insurance out of their salary. Okay. And doctors are just like everybody else. They have to pay for their own health insurance. Okay. Okay. In the United States, there are many more doctors in certain areas than others. And those are the areas, of course, where people want to live. Those are the coasts, the New York side and the California side. So there are lots of doctors on the East Coast and the West Coast of the United States, and many fewer doctors in the Midwest. And in the Northwest, even fewer doctors. So in states like North Dakota, states like Alaska, there's a need for physicians. The need for physicians in the United States is increasing now very, very quickly. Does anybody know why within the last 1 year the number of doctors' office visits has increased extremely quickly in the United States within the last year? My friends, you tell me why. Yes, excellent. Excellent. Yes, Faisal Khalid got it right away. Right away, okay. It's Obamacare. That's right. We have a new system in the United States which is helping poorer people, more poor people, get less expensive health care, and that's Obamacare. Now, Obamacare does not involve the government paying for health care. It is not socialized medicine. It is encouraging private companies to provide health care to patients in the population with a variety of incentives. Okay, so Obamacare, our president has instituted healthcare reform in the United States. Because more people can now afford healthcare, there is a greater need for physicians. And physician shortages are becoming a problem even more in the United States. So this is good news for people from outside of the country who would like to practice in the United States, because there will be many more patients and many more patients who will be paying through more affordable care, affordable health insurance. Okay. Faisal says, but everyone has to buy health insurance or else they will pay a fee. Yes, that is correct. The fee is extremely low. It is not a problem fee. It's sort of just a little slap on the hand if you don't buy insurance. Everybody is expected to have insurance. And this is very helpful for physicians as well, because people will be able to pay. So people have to sign up for health insurance, and they do that online, and it's not easy. It's a little bit difficult to do, but people will be covered. Okay. The fee is very small. It is not a lot of money. It's a very low fee. If they don't get it, why bother with a fee at all? Okay, Faisal? Okay, if you have any more questions, I can certainly answer them. But I'd like to describe more the healthcare system in the United States. The average length of hospital stay in the U.S. has been declining steadily. That is, for example, for a normal delivery of a healthy baby, the usual hospital stay back in the 1970s was about 3 or 4 days. Nowadays, if a woman comes in early and has a normal delivery, she's lucky if she can stay overnight in the hospital. She probably will be going home by the evening. Okay, and that's not because care is better for women who've just had babies. It's because the insurance companies have decided that they will only pay for a certain amount of time for each illness. And if the insurance companies pay for example, 1 day hospitalization for a normal delivery, and the mother would like to stay 1 or 2 days more, she can do it, but she'll have to pay out of pocket. And since it is at least $1,000 a day for her, and now she has a new little friend who's also costing $1,000 a day, that's $2,000 a day for mother and child. she's going to get out of the hospital as soon as the insurance company says leave. Okay? So the insurance company has decided, companies, and there are many private insurance companies in the United States, has basically said we have to shorten these hospital stays and make the costs less for the insurance companies. Okay. Therefore, there are many hospital beds that are unfilled in the United States because the hospitals were built when insurance companies were paying for more days in the hospital. And as they decrease the number of days they'll pay for, there are more and more unoccupied hospital beds. In the neonatal nursery, we used to see 30 babies, 35 babies at a time, and now we see about 5 or 6 at a time staying in the neonatal nursery because everybody else has gone home. Okay. So hospital personnel are the most expensive part of hospitalization. White Americans go to private physicians about 10 times as often as African Americans, and we talked about this yesterday. We talked about the fact that African Americans have incomes that are about half that of white Americans. And remember that going to private physicians is expensive. People with either money or insurance will go to private physicians. Poorer people will go to hospital emergency rooms, even for non-emergent conditions. So what we see in a lot of hospital emergency rooms is mothers with their children. Children have ear infections. Children have throat infections. They cannot go to a private physician because they cannot pay. And so they go to the hospital emergency room for stabilization. Now, the hospital emergency rooms charge more than physicians' offices charge. However, they must stabilize, as I said, every patient who comes to them, and the patients will get a bill, but they will be unable to pay the bill. And ultimately, the state will probably have to pay those bills. Okay. Okay. Now, if any of you want to practice for any time in the United States, you have to get a license from the state board that you are practicing in. So whatever state you decide to live in and practice in, that state has to give you a license. And I did mention this also yesterday. So physicians are licensed by the state they practice in, and typically that is by the State Board of Medical Examiners, which is composed of physicians who practice in that state. Okay. So the state medical examiners give you your license when you show them your credentials. And as I mentioned yesterday, they can also take away your license if you commit errors or do not follow the ethical standards of the profession. State boards very rarely take away a doctor's license, but they may give a doctor a warning. For example, a doctor is practicing while under the influence of alcohol. He is reported by a colleague, and it is your job to report such occurrences as colleagues, and the State Board of Medical Examiners suspends his license temporarily while he goes in for treatment for his alcoholism. When he comes out of treatment, the state will reinstate his license and do regular checks, urine checks, for example, to be sure that he is not using alcohol again. So they'll come unexpectedly and ask for a urine sample for a variety of different drugs, depending on which one the doctor has been using. Okay. So you are regulated as physicians by the individual states that you practice in. Okay. Mental illness. Now there has been a decrease in the need for hospital beds for mental illness, and that's good news. And it isn't so much that insurance companies have refused to pay for mental illness, although some of them do, but rather that we have better treatment now for people with mental illness that allows them to live independently more often. Okay. And the treatments, of course, are the specific medications. We have more outpatient treatment. patients get out of the hospital quickly because we have antipsychotics and antidepressants. And also the idea, and this is a pervasive idea in the United States culture, that people should not be taken out of society, that people should be mainstreamed into the rest of society as much as possible. That is, people with mental illnesses, people with disabilities should be encouraged and helped to stay in general society and not to be separated out into any type of institutional setting. Okay. So even in public schools in the United States, children who have handicaps are given special help to stay in regular classes. They may have special needs teachers for their special needs. If they have autism, if they have mental retardation, they will have special classes with special teachers, free. It doesn't cost anything. Special education is free in the United States for many, many different reasons. And the child will be kept in the regular classes for their music class and art class and for gym class, but they will be given special education for their reading or whatever it is that they need. Okay, so the idea is to keep everybody in the mainstream of society, and that includes the mentally ill. It wasn't until 1950 that the first antipsychotic was developed. And from those, ultimately the antidepressants were developed. And these drugs changed the lives of mentally ill people. Because rather than just sedating people, which is what happened to people with mental illness prior to 1950, all we could really do for them was to give them a sedative so that they couldn't hurt themselves or anybody else. Now we had medication that would control their hallucinations, their delusions, their depression without sedating them. So they were not sedated, they were able to work or at least to take care of themselves, and they didn't therefore have to be hospitalized. So the medications made the big difference back in the 1950s when they were first developed. Okay. Okay, now we know a little bit about the healthcare system. Let's see if we can answer this question. Of the following patients, the one likely to use the least Medicare services and funds is which of the following patients? African American woman, African American man, Caucasian woman, Caucasian man, or Asian American woman? Who is going to use the least Medicare services? Let's use your clickers, your counters, my friends. Rather than putting the answer on the public chat, let's put it on the clicker. Let's put the timer up, my TA. Thank you. Who's going to be cheapest for the federal government? Remember, Medicare is for the old and is paid for by the federal government. And Medicare, you start getting at 65 and you collect it, basically, healthcare services until you die. So who's going to collect the least? Who's going to be cheapest, as I said, for the government? Okay. Well, we seem to have a little confusion with this question. A little bit of confusion. Okay. I'm going to give you another few seconds, my friends. Okay, because I see a number of you have clicked in, but you're all over the place. There is no one that's getting a lot more. Okay. Who's going to be cheapest for the United States government? The answer is B, an African American man. Now you're going to tell me why an African American man will be cheapest for the government. Ah, Ibrahim, very good. Let's see if anybody else gets that. I guess you can see Ibrahim's response. That's right. That's right. because African American men of all of these groups have the shortest life expectancy. Okay. Men have a shorter life expectancy than women. African American people have a shorter life expectancy than the white population because of healthcare availability and costs. Okay. Men do die earlier than women, right? About 7 years earlier. The longest lived group on this list, my friends, who is the longest lived group? Let's start the counter. Who lives the longest? Who's going to cost Medicare the most? Who lives the longest here? Who lives the longest? Are you clicking in? Okay, we have to clear the counter from the last question, my friends. I see, some of you are saying C, who lives the longest, but some of you correctly are saying E. Yes, it is the Asian American woman. Asian Americans have a longer life expectancy than the Caucasian population in the United States. The average life expectancy for a Chinese American woman, which is the longest of all of the longest lived of all of the Asian groups, is Chinese American, is about 90 years. That's right. Okay. And the average life expectancy for African American men is about 68 years. So the government starts paying at 65 for your health care, but by the time he's 68, the African American man has died and isn't costing the government anything anymore. Whereas the Asian American woman is living until she's 90 and she starts collecting Medicare at 65. Okay, my friends. Okay, this is our next topic, and that is mandatory reportable diseases. When must you, by law, as a physician practicing in the United States, report the illness that your patient has to the state that you're practicing? And here we say the local public health department. That means the state health department. Okay, I'm just going to make a note for myself to fix that rather than public, to say state. Okay, health department that you are practicing in. The state health department will then inform the federal government. The Centers for Disease Control and Prevention, the CDC, is a federal agency. Okay. So it must be reported to the state. Now, this is because the illnesses that are reportable to the state pose a threat to the health of the public. Okay. And these are the diseases that must be reported to the state. In almost every state, the diseases are the same. So for federal exam, what we're taking here, the federal licensing exam, the United States medical licensing exam is good across all 50 states. Okay. So they can't really be very specific about differences among the states in what is reportable and what isn't, and what is legal and what it isn't, because states have individual laws as well. They will go by federal government standards for the boards. Okay. So the most reported disease is chlamydia. There are a number of other sexually transmitted diseases on here. The childhood infectious illnesses. AIDS is reportable in every state, but HIV positive status is not reportable in every state, only in some states. Okay. Should you memorize the table, Ahmed? No, you should not memorize the table. There are a couple of mnemonics that students use to try to remember them, and I would say it's important to remember the first 10 or so. Okay. So the numbers, they do switch around. Sometimes one is reported more than the other. Lyme disease is reportable even though it's not communicated between people. So some of them, just if they pose a public health threat, are reportable. Okay. Now when we say reportable, the diseases are reportable to the state that you are practicing in, not to the patient's partner. Okay. So if you have identified a sexually transmitted disease in a patient, you are required, if it is one of these STDs, to report it to the state. The state will then get the patient's information and contact the patient as to who their contacts have been, who has been exposed to this disease. The state will then go to the people that are exposed, that the patient has identified, and tell them they've been exposed without revealing the patient's name. That is kept confidential. So they will contact the person and say, for example, you have been exposed to gonorrhea. We cannot tell you who exposed you, but we have information you've been exposed. So these are your options. It's up to you, but these are your options with respect to getting diagnosed and treated. Okay. So that's the job of the state agency that deals with these mandatory diseases, reportable diseases. Okay, let's take a look at this question. The voluntary behavior, and we're going to clear the counter, my TAs, and we're going to start the counter when we finish reading this question, okay? The voluntary behavior responsible for the most deaths in the United States is it tobacco, poor diet and inactivity, or alcohol? Okay, we can start this 30-second counter. Good. Which one is it? Okay. Use your clickers. You're welcome. Okay, so we have lots of different people choosing different things. We're almost done. Time's up. Okay, well, the answer is smoking. Smoking is the most dangerous of all the bad habits that people have. And if you could eliminate smoking, you could increase the life expectancy in the United States to some extent. Okay, so smoking is it. So if we look at the comparison here, smoking is higher than diet and inactivity, with alcohol lower. Okay, my friends. Okay, and because smoking is so high in the United States, we have increases in female lung cancer rates. In the old days, women did not smoke. That is back in the 1900s, early 1900s. But more and more women are smoking, and female lung cancer rates are increasing. And it is now the #1 cause of cancer mortality in women and in men. So if we look at cancer mortality, with the exception, of course, of skin cancer, which doesn't come into these tables because it so rarely kills you, the incidence rate, the number of new cases of prostate cancer, prostate is the highest number of new cases for men, with lung cancer second and colorectal third. For women, it's breast cancer, lung cancer, and colorectal. But the death rate, because the case fatality rate is much higher for lung cancer than for prostate and breast and colorectal cancer, the death rate is higher. There are more deaths from lung cancer in men and in women than from the other common types of cancer. Okay. But of course, as I said, skin cancer is the most common cancer for either gender. And this is a basal cell carcinoma, very, very common type of skin cancer. It is the most common type of skin cancer. Melanoma is a very deadly type of cancer, but it's also quite rare. So skin cancer generally is a very low cause of cancer deaths. And of course, lighter skinned people are more likely to develop skin cancer. Okay, so here are the causes of death, and these switch around every year. But heart disease and cancer, as you can see, are far and away the highest causes of death. Okay. Okay, now if we look by age group, and we're going to stop in just a minute when we finish this section, we're going to take a break. But if we look at the different age groups and the leading causes of death by age group, We can see that in infants, congenital anomalies, short gestation, and sudden infant death syndrome, SIDS, are the highest causes of death. If we look across the childhood years all the way into the beginning of middle age, unintended injuries are the leading cause of death. If we look at the middle-aged group, cancer is the leading cause of death up to age 65. Okay, and if we look at the elderly, heart disease is first, which makes heart disease overall first, since most people who die are over 65. Heart disease, cancer, and stroke. Okay. I'm going to put this question up, and I'm going to leave it up for the break. Okay, my friends? So let's leave it up for a minute or so after we break, my TAs, okay, to allow the students to look at the question, and we will do the timer and answer it, a typical board question, when we come back from our break. Okay, my friends, it's time for our break. See you soon. 10 minutes. Okay, welcome back, everyone. I have left this question up for you. Can everybody hear me okay? Oh, yeah? Okay, good. Okay, so parents bring their 8-year-old child in for a school physical. Both of the parents smoke cigarettes. The child plays soccer, swims, and bicycles. In order to protect the child's life and health, which is the most important suggestion the physician can give to the parents? So we have stop smoking. We can start the timer. Okay, stop smoking to reduce the child's exposure to secondhand smoke. Put smoke alarms in the home. Have the child wear a helmet while bicycling. Learn CPR. Or be sure that the child wears a seatbelt in the car. Okay, my friends. What do you think the answer to that one is? And click it in. Okay, our time is up. Okay, and I see most of you picked A. 65% of you picked the first one, but the answer, which 11% of you got, is be sure the child wears a seatbelt in the car, because deaths, accidental deaths in children, which we saw was the highest cause of death, are primarily in cars. Okay, and primarily because the child was not wearing a seatbelt. So the most important health intervention is to wear a seatbelt in the car. Now, stopping smoking. Smoking has been associated with increased ear infections, upper respiratory infections in children, but not with the death of children. Okay, so there's really no clear answer about secondhand smoke, but it does seem to be associated with more respiratory problems in children. Smoke alarms for house fires, luckily they're relatively rare. Have a child wear a helmet, certainly that's important, but that is not the way most children are injured or die, that is on bikes. Learn CPR. There are some homes with private swimming pools, but most children don't have access to a private swimming pool or other means of having their breathing interrupted. But this one, every American child is in a car every day, pretty much. Okay, they may be in a bus going to school, they may be in a car, but American children are frequently in cars, and that is the leading cause of death, accidental death in children. That is death in cars. Okay, my friends? How are we doing on that? Any questions on that question, my compatriots here? Good, okay, got it? Good. The answer, by the way, seatbelts in cars are the main problem with many people. They had a question on the boards recently where they had a policewoman, okay, smokes 2 packs of cigarettes a week. She drinks 1 glass of alcohol, of wine a day. She is in a rather dangerous, works in a rather dangerous area. She carries a gun. And sometimes she wears her seatbelt in the car, and sometimes she doesn't. What is the thing that you should first instruct her to do? And they have choices like stop smoking, stop drinking the wine, join another, get another career. And the answer, of course, is wear your seatbelt all the time in the car. Okay, so that's what the answer is going to be. So remember seatbelts for the USMLE. Okay, and here are some causes of death patterns in minority groups in the U.S. So these are just some of the minority groups in the United States. And what you can see here, the plus means higher than the white population. The white population, of course, is the largest group in the United States. About 11% of the Americans are African American. About 12% are Latino, that is from Spanish-speaking countries. Okay. We have about 1% Native Americans. And we have at the moment about 6 or 7% Asian Americans or Asian Pacific Islanders, which all of these individuals do not have any increased risk of any of these problems, health problems, when compared to the white population. But you can see that the African American population, for all of these conditions, has a higher death rate for those than the white population, with one exception. And that exception is suicide. Suicide rates are very low in the African American population in the United States. Some of the factors associated with that have to do with strong family support, community support, and particularly support of the church. Okay. Okay, and the other groups are mixed. Now, this is a relatively new factoid in the United States. If we're just looking at the white, African American, and Latino groups, which is the longest lived group in the United States? Let's start our counter. Which is the longest lived group in the United States? Counter, timer. Okay, thank you. This looks really easy, but it's not so easy. That's a hint. Okay, how are we doing? Well, we have a toss-up here. Okay, and the answer is Latinos. Have shown that Latino, that is Spanish-speaking peoples in the United States, which are the largest minority group at the moment, have a longer life expectancy than the African American and white population. And you might ask me, why is that? Well, that's the question that a lot of people would like to answer. We don't know. We don't know whether it is dietary, genetic, or some other factor that has not yet been identified. There have been some that have said that the Latino people that come to the United States from those Spanish-speaking countries, primarily in Central America and the Caribbean, Mexico, Puerto Rico, may be in better health to begin with when they come to the United States than other people in the culture. So it may just be those that come to the United States. Okay. Why not A? Good question, Ahmed. Okay. We don't know what it is at this time. Okay. Okay, infant mortality rates for 1,000 live births. If we look among the American public, we will see that the overall infant mortality rate in the United States in 2005 was 6.9. It is going down every year, luckily. You can see that African American infants have a much higher mortality rate than white infants. Okay. Native Americans also have a somewhat higher mortality rate. And if we looked at the infant mortality rate in the United States versus that of other developed countries, where do you think the United States falls in infant mortality? Do we have a high rate, a moderate rate, or a low rate for infant mortality compared to the other developed countries of the world? Okay, we have a lot of people saying low, and that's not right. The answer is on this slide. Okay. Now, I know it's very hard to see this. I hope you can see it more clearly than I can. Okay, this is from the CDC, Centers for Disease Control. International infant mortality rates. Singapore and Hong Kong have the lowest infant mortality rates of all of the developed world. Japan is up there too, and Sweden, Norway, Finland. So the Scandinavian countries have a very low infant mortality rate. Here are some of the other developed countries. And where is the United States? All the way up here. The United States has a very high infant mortality rate compared to the rest of the developed world. Cuba is the only country that is higher, and you might argue about Cuba being a developed country. But currently, Cuba is below the United States. So the United States has assumed the first place in infant mortality in the world among developed countries. So why is this? It has to do directly with our healthcare system. In most of these countries, prenatal care is given, is free. That is, it comes with your health coverage from the government. Okay, and you pay for that health care in your tax dollars, but not specifically for health care. Okay, you pay very high taxes to the governments of these countries. The tax rates are much higher than they are in the United States, but all of your health care, including prenatal care, is covered. In the United States, if you want prenatal care, you have to go to a doctor and pay for it. Okay? There are some private organizations that provide free prenatal care to persons who can prove that their income is low enough to get free prenatal care. But prenatal care costs the same as any other care in the United States. So if you don't have the money, you don't get prenatal care, and those groups, particularly African Americans, have a very high infant mortality rate. Okay, my friends. Which brings up the overall rate for the whole country. Okay, so we talked a little bit about this already, and that is that Medicare, care for the old, pays for the elderly. That is, once you're 65, you get your health insurance. And the health insurance, Medicare, is provided through the United States Social Security Act. That is, Social Security is the federal pension that Americans collect when they're around 65. It's a little bit older now, it's 66 or so. You can begin to collect your federal pension, that is, your money from the government. Now, all your working life in the United States, you put in to the Social Security and Medicare system. Every paycheck that you have in the United States will have a deduction for your future Social Security and for Medicare. Okay, the government will contribute, and your employer will also contribute to Social Security and Medicare. And when you're 65 for Medicare and 66 or so for Social Security, you can begin to collect your monthly benefits. Okay, now Medicare also covers people who are chronically disabled. That is, they have been disabled for at least 2 years, and they are expected not to be able to work again. So Medicare will cover that group also. Part A of Medicare doesn't cost anything to the recipient of the care, and that covers hospital bills almost completely. Part B covers 80% of doctor's bills. And if you decide in the United States, if you do practice here, that you want to be a participating physician in Medicare, you will accept that 80% as your full payment. Okay. You can be a participating doctor or not, as you like. Okay. Medicaid, and I mentioned that, is for the very, very poor of any age. And that covers hospital bills, doctor bills. It also covers dental costs and eyeglasses. You can see that Medicare does not cover dental bills. People generally have to pay their dental bills on their own. And one way of telling the socioeconomic status of a patient is to look at their teeth in the U.S. because people who are poorer delay getting dental care and tend to lose their teeth earlier. It's very expensive to restore a tooth. So one single restoration with a root canal and a crown on a tooth can cost $4,000 or $5,000 for one tooth. Okay, and you have 30 or so of them in your mouth, so that could be quite pricey. Okay, and poorer people cannot afford to pay that, and insurance doesn't cover it. Medicaid, interestingly, does cover dental insurance. So if you are very, very poor and you have actually no assets and no job, you will be covered if you apply to Medicaid. Now, certainly Medicaid checks back. They check your income. They check through your federal tax filings to be sure that you, in fact, do not have any income. Okay, now we're on to our next chapter, and that is substance abuse. And this is something that you cover in other parts of your courses. Substance abuse is a problem in the U.S. It's a problem in many places in the world. It's not exclusive to the United States. People take drugs for a variety of reasons. There is what we call self-medication hypothesis. That is, people feel depressed, or they feel anxious, or they feel physically unwell, take drugs to make themselves feel better. And certainly most drugs of abuse work through the dopamine pathway, and dopamine is the feel-good neurotransmitter. It is also the stimulating neurotransmitter. As you know, dopamine stimulates the heart. Dopamine increases sexual drive. It wakes you up. That is, amphetamines primarily are dopamine agonists. They increase dopamine. So that is the basic addiction pathway. Serotonin is a relaxation neurotransmitter primarily. Serotonin is involved in some of the drugs of abuse, particularly the hallucinogenic drugs involve elevation of serotonin. Okay. I want to show you this. Yes, we have a real problem in the United States with prescription drugs, and the fact that prescription drugs are out there and are very often used as drugs of abuse. This is an actor, Heath Ledger. You may have seen him in Batman or in some other show, movie. This movie was called Brokeback Mountain, and he starred in that movie. He died at the age of 27 from a drug overdose. Okay, and here was, in 2008, he was 27, the medical examiner's report: death due to acute intoxication by the combined effects of oxycodone, hydrocodone, diazepam, temazepam, alprazolam, and doxylamine, which is an over-the-counter sleep agent, an antihistamine. Okay, so these were all in his system at his autopsy. There is no information that he was suicidal or even that he was depressed. It was ruled as an accidental overdose. So sometimes we don't know, Amir, whether we're talking about suicide or quote-unquote an accidental overdose. Okay, it looks like my webcam has stopped for now, my TAs. Can we do something with the webcam? Okay. I'm going to stop the webcam. And I'm going to try to start it again. Okay, I turned it off. Carrie, I'm right there. Let's see if we can get the webcam to work. Okay, I think we have another problem again today with the webcam. It was working for a second. Okay, let's stop it again. Let's see if we can get it to come back. Anyway, I'll keep on talking. You know, it's really hard to get me to stop talking, my friends. Okay, so we're going to see if we can clear up the webcam problem, which we also had yesterday. Okay, in the meantime, we'll continue. So this was a very sad story of somebody who was nominated for an Academy Award, was a very fine actor. He actually was an Australian. He was originally from Australia. But he died in the United States. It's a very sad story. And it was prescription drugs. And prescription drugs are responsible for more deaths in the United States than any drugs of abuse. Okay. Okay, here's our alcoholic. This is the person who apparently just lives on the street. You can tell he's not very well groomed, to say the least. Okay. He shows some of the stigmata of alcoholism. He has the broken blood vessels on the nose and across the cheeks. He has a swollen gut. The rest of him doesn't appear to be quite as heavy, but his stomach area is very swollen. So we don't know what the significance of the 3 fingers is. If anybody has an idea, please type it up. Okay. I think he has 2 bottles of wine and he wants one more. That's what I think the 3 is all about. So this is a very costly and big health problem in the United States and in other places in the world as well. Okay. Okay, my friends. So how are we doing? Can you, all of you, hear me? Okay, excellent. Okay, well, you can still hear me, which is good news. Thank you, thank you. Good news. Okay, great, terrific. Okay. Okay, so let's, in every culture, alcohol is the most abused drugs, and this has been since the beginning of time. The first time a caveman left grapes out in the sun or let them ferment without meaning to and then ate them anyway and got a really strange feeling in his head, alcohol became a drug that people used. So it's very available. It's very, very common. About 10% of American adults drink to the extent that it causes them some difficulty in their life. And that's what we would say would be a problem drinker, aka an alcoholic. Okay. It's implicated the use of alcohol in many things like auto accidents and deaths in cars, homicides, suicides, abuse, child abuse, elder abuse. People in the United States sometimes abuse the elderly, and domestic partner abuse, spouse abuse. So alcohol is implicated in many, many problems in the U.S. This, spiders, is reminding me of a board question. An old woman is admitted to, I'm just making a little note for myself, is admitted to the inpatient unit. Rather, she's admitted to inpatient in a hospital. She's admitted because she has broken her femur. Okay, so she has a serious fracture. She is surgically stabilized. Her health is, she's doing well physically. 2 days after the surgery, she complains that there are spiders crawling on the walls. And she feels them crawling on her arms. So she's having visual and tactile hallucinations. Hallucinations are false perceptions. She's feeling and seeing spiders when there's nothing there. And the question is, what is causing these hallucinations? Okay. And the answer is, how about giving it a try, my friend? Since you see the slide that we're on, tell me what is causing her hallucinations and delusions. Well, Haya, it is that she has an alcohol addiction, you're correct, but Ahmed is correct in that after 2 days in the hospital, she's going through alcohol withdrawal. And what she's experiencing is alcohol withdrawal delirium, which we'll talk quite a bit about. Alcohol withdrawal delirium does not just include psychotic features like hallucinations, but it also includes seizures and cardiovascular collapse, which are life-threatening. So sometimes we have someone in a hospital situation and we don't know that they've been drinking excessive amounts of alcohol. So we are not treating them for alcohol withdrawal, and they begin to show these dangerous signs. Okay. So what will we give this woman now that we know or we suspect that she is in alcohol withdrawal? What will we give her? Okay. What do we give somebody who's showing alcohol withdrawal? Okay, now in some countries, Ibrahim, they use ethanol itself. But in the United States, that is not done. Said is correct. We would give her a benzodiazepine. Benzodiazepines and alcohol are in the same family of sedatives. Diazepam would be okay. We'll tend to use one of the benzos, though, that has less abuse potential, one of the longer-acting benzos. Okay, but a benzodiazepine will bring her out of this state. She is currently delirious, okay? In the state of delirium, which in this case is caused by alcohol withdrawal, patients often show psychotic symptoms. Now, let me just define psychotic for you. Psychotic symptoms are hallucinations and delusions. Hallucinations are false perceptions, like the spiders, in any sense. And delusions are false beliefs. False beliefs not held by others and not part of a culture or a religion. Okay? So if a patient tells you that they believe something, you want to always ask the patient, do other people in your culture believe that as well? Or are you the only person who believes that? And people with psychotic symptoms will say, I'm the only one who knows that, okay? The other people, they don't know about it yet, okay? If someone says, yes, everyone in my culture believes this, then that is not a delusion. It is a cultural belief or a religious belief. Okay, my friends, and we'll see that later on coming up. Okay. Fetal alcohol syndrome is an important cause of mental retardation in children, and women, of course, are advised to forego alcohol completely during pregnancy because of this. Okay. And there are signs in places that serve alcohol that say something like, a pregnant woman never drinks alone. Okay. And that's supposed to stop pregnant women from drinking alcohol. And in fact, they do drink a lot less alcohol than in the past. Okay. There is a genetic contribution. We know that identical twins are more likely to both be alcoholic than non-identical twins. So there is a genetic contribution. We know that the children, particularly the boys of men who have a problem with alcohol, are more likely to have a problem. There are ethnic group differences in the world. There are some countries of the world that consume more alcohol than others, as you know, and the English-speaking countries are the biggest consumers of alcohol in the world. That is Ireland, Scotland, England, the United States, Canada, Australia. Okay. Is that a genetic thing? Probably not, because the United States is made up of so many different cultures. It seems to be more of a cultural difference rather than a genetic contribution. Okay. Children who are adopted tend to drink the amount of alcohol that their parents drank. Okay, that is their biological parents, even if they are adopted. And that's again evidence for a biological contribution. Okay, let's take a look at this question. A physician is doing an employment physical on a 40-year-old male patient. The doctor suspects that the patient is an alcoholic. Okay. The next step that the doctor should take is to ask him the cage questions, check his liver function, ask him if he has a problem with alcohol, call his previous employer for information, or check for the stigmata of alcoholism. Okay, let's put up the 30-second timer. Okay, let's see how we did. Some of you are still answering. You will on the boards have a minute for your questions. When you take the actual board exam, slightly more than 60 seconds for a question. Okay, well, let's see. Well, you're switching around, some of you are switching around your choices. Right now, though, we have A has answered, 46% of you have picked choice A, and that is the correct answer. And some of you may not know what the cage questions are, okay? So let's talk about what they are. If we ask somebody who is an alcoholic, if he has a problem with alcohol, what is he going to say? He's going to say, no, not me. I can stop anytime I want. That's right, Hyatt. He'll say no. He'll say no. So we don't ask those questions directly. People are in denial typically when they have a problem with a drug. They don't believe that there's a problem. They think, as I said, that they can stop at any time. So instead of that, we ask the patient these 4 questions. Have you ever tried to, there's the C, cut down on alcohol intake and not succeeded? Trying to cut down indicates you have a problem with it. Otherwise, you wouldn't try to stop. Are you annoyed about criticism concerning your drinking? Do you feel guilty about your drinking behavior? Or have you ever had to take a drink as an eye-opener in the morning to relieve the anxiety and shakiness? What is the anxiety and shakiness, my friends, that an alcoholic will experience when they first wake up? Why does a person who's an alcoholic experience shakiness? Very good. A couple of you have it. I'm going to wait for some of the others. Let's see. Okay. Hangover, Khalid. That's right. It could be called a hangover. That's a common term for the way you feel if you drink a lot the night before when you wake up in the morning. They're in withdrawal. That's right. There is, in the early morning hours, people who are heavy alcohol drinkers will experience withdrawal when they first wake up, and they take another alcoholic drink to stop the shakiness and anxiety. Okay. This last one alone is pathognomonic for alcoholism. If the patient answers yes to this, that is alcoholism, or any 2 of the others. So if you get 2 points on the cage questions, each one of these first 3 is worth 1 point. This one is worth 2 points. Any 2 points, and you have a problem with alcohol. Yes, hangovers can be relieved with more alcohol, but you're sort of getting yourself back into the same problem again. Okay. Sometimes the drink that you have in the morning after when you have a hangover is called, quote, the hair of the dog that bit you. Okay, so you get a little of the hair of the dog that bit you. That means get a little more alcohol on board. That's what people do. That is not the ideal thing to do. Okay. Okay, The most effective treatment for alcoholism is a support group of peers called Alcoholics Anonymous. This is groups of people who get together. They don't charge anything. These meetings are free. They all talk about their problems with alcohol and help each other. And the reasons it's called Alcoholics Anonymous is that nobody knows your last name. Okay, people do not use their last names. Therefore, you cannot be identified by relatives, employers, police. You just use whatever name you want to use in a meeting. Okay, you can use your own first name or you can make up a name, but this is the most effective treatment. And the way that Alcoholics Anonymous works is that they have developed a 12-step to recovery program. And I'll show you a few of the steps in just a minute. Nobody knows your last name. It is the most successful treatment for alcoholism. There are meetings every day of the week in every city in the United States and all over the world. Okay. And it doesn't cost anything at all. And this is Bill W. He uses his last initial W. Does not, he's the person who started Alcoholics Anonymous. So there are many other, by the way, anonymous programs besides AA. There's Narcotics Anonymous for people who want to get off heroin. There are groups like Gamblers Anonymous for gamblers, or Overeaters Anonymous. There's even one called Shoppers Anonymous, okay, if you have a problem with shopping, okay. Okay, so the first step in all of these programs is to admit that you are powerless over whatever the problem is. In this case, it's alcohol. Fourth step is try to go through the things that you've done because of your alcohol use and make a list of all the people you've harmed and make amends to all the people you've harmed because of your alcohol use. And the final step in these 12-step programs is try to help other people who have the same problem. Try to carry the message to others. Okay. If the patient will not go to AA, family members can go to different meetings. A meeting of family members of alcoholics called Al-Anon, which deals with how they may be inadvertently, not meaning to, somehow helping the alcoholic get away with his drinking, making excuses for him to friends, saying that he's sick to his boss, for example. So these issues are dealt with in groups like this. Disulfiram is a drug that's used as an adjunct. It blocks the breakdown of alcohol so that when somebody drinks alcohol, they become very nauseated, tachycardia, vomiting. They feel very ill, and they're supposed to, by conditioning, and we'll talk about conditioning a little later on, make an association between alcohol and feeling sick. Okay. If you give a rat alcohol enough after you give him disulfiram, he'll never look at alcohol again. But people are not as smart as rats, okay, and that doesn't work very well for people. Okay, so the most effective treatment is Alcoholics Anonymous. Okay, now I put the rest of the drugs into groups so that we can, you have a big table in the notes. I've kind of condensed it into 4 slides. Okay, these drugs all have very similar effects of use and withdrawal. These are the stimulants. These drugs all work by increasing dopamine in brain synapses, either by being dopamine agonists like the amphetamines, or blocking dopamine reuptake like cocaine. Okay. Okay, so Haya's asking, if people know that the nausea is due to disulfiram, they know it's not the alcohol but the drug. The idea is that in classical conditioning, you may know something, but that your body will still respond negatively to anything that's been associated with something that has made you sick. Okay, so it benefits some people higher. You're right. It's not necessary. What people do is they just don't take disulfiram on the day they want to go out drinking with their friends, okay, because they know that it'll make them sick. So it is a secondary treatment for alcoholism. Okay. So cocaine blocks reuptake of dopamine. Caffeine and nicotine work to increase dopamine as well, but they are the little baby stimulants. But all of the drugs similarly can elevate mood, even caffeine and nicotine to some extent. They all stimulate the heart, so they all increase heart rate. They cause pupil dilation. They cause, all drugs, even caffeine and nicotine, decrease appetite. And caffeine is the main ingredient in over-the-counter diet medications. But high levels of dopamine are associated with, yes, mood elevation, but mood elevation that can become so intense that the patient has psychotic symptoms. They have hallucinations, delusions. Paranoia is suspiciousness. Their delusions are often paranoid delusions that somebody is trying to harm them when somebody is not. And remember that drugs can be taken many different ways. They can be snorted into the nose. They can be injected. They can be taken in pill form. Amphetamines can be taken in pill form. All drugs can be taken in a variety of different ways. Patients who are taking cocaine very often are quite fearful, suspicious, anxious because of the drug. Okay. So intoxication leads to these symptoms. Withdrawal leads to the opposite. That is increased appetite rather than decreased appetite. Fatigue rather than energy. Depression rather than euphoria, which is mood elevation. Headache. All of these things we see in withdrawal. But you'll notice that the withdrawal symptoms from stimulants are really primarily psychological. There really is nothing very much in the way of physical withdrawal symptoms like you would see with heroin. Okay. The management, if the patient is psychotic, we give an antipsychotic. We can give medications for headache as well, if the patient has a headache and withdrawal, rather than giving them more stimulant, more caffeine, okay, more amphetamine. Okay. The sedatives. Here are the sedatives: benzos, alcohol, barbiturates. Impaired judgment is very similar with all of these drugs. Slurred speech, lack of coordination, stupor, ultimately a coma, and death. The barbiturates are the most dangerous of the group in overdose. Alcohol is next, and then the benzos. And particularly combinations of alcohol and benzodiazepines are additive and very dangerous, or alcohol and barbiturates. Okay. Withdrawal is life-threatening. Patients must be hospitalized for withdrawal because of the autonomic hyperactivity, psychotic symptoms, seizures, and cardiovascular collapse. So in the emergency room, we give the patient a sedative, typically a benzodiazepine, for detoxification. Long-term management for alcoholism, anyway, is Alcoholics Anonymous. Okay. Okay, here is heroin. And heroin, you can see here, is being injected under the skin. It can be injected into a vein as well, and you need less heroin for the effects if you inject it into a vein than if you inject it under the skin. So it's cheaper to inject it into a vein. It can be snorted into the nose. It can even be smoked. Okay. Heroin is illegal in the United States. Alcohol is legal, right? Is legal. Heroin is illegal. But analgesics are also opioids. They are legal, and they are prescription medications. And the effects are very similar for all opioids. Okay. Just one moment. Okay. Okay, so intoxication. And this is a pathognomonic for opiate overdose. That is pupil constriction. slowed GI tract. All of the opiates slow down the GI tract. And when you're using an opiate in an elderly person, they will often complain of constipation because of slowing of the GI tract. It's something we always have to be aware of, particularly in the elderly. Slurred speech and drowsiness, respiratory depression, and an overdose of an opioid, and we've talked about this, can kill. Okay. Withdrawal is a very uncomfortable syndrome, which is a classic syndrome. Pupil dilation, nausea, diarrhea, the GI tract goes into overdrive, okay? Runny nose, fever, muscle aches, yawning, goosebumps on the skin, tearing eyes, hiccuping. This whole picture makes the patient feel, they will tell you, sicker than they've ever felt in their life. However, it, as you know, is not a dangerous thing. That is, a person can withdraw without any further problems. They are not going to die in withdrawal, as a rule. Okay. The management of opioid addiction is to detox using another opioid, very much like we use a benzodiazepine for alcohol withdrawal. But we use another, or a legal opioid, one of the pain medications. And for long-term management, we often use a opioid and keep the patient addicted to an opioid. And people say, well, why would you do that? Why would you use a drug like methadone, which is an opioid, so that the patient remains addicted? Okay. Oh, I see a question, let's see, by Amir. Which substance withdrawal can cause death? The answer is alcohol, benzodiazepines, or barbiturates, the sedatives. Okay? Okay, Amir. Okay, now the opioids are not dangerous in withdrawal, but very, very uncomfortable in withdrawal. So now, in the United States, people who are heroin addicts, because we know that it is the most effective treatment, can elect to join what's called a methadone maintenance program. A methadone maintenance program provides addicts, heroin addicts, with an opioid in high doses for as long as they need it. Now, why would we do that? And I mentioned this before. We do this because methadone does not have the mood-elevating properties of heroin. It's also legal, okay? So the heroin addict does not have to find the drug illegally. It is used through the federal government. That is, the government provides the methadone for registered addicts. The federal government runs the program, and it is the most effective management long-term for heroin addiction. Most heroin addicts will go back to using heroin after detoxification. That's when you get the drug out of somebody's system. Okay. So a methadone maintenance program is the most effective management for heroin addiction. Now we have a new method of management. I mentioned that methadone is given through the federal government. The federal government administers these programs. You have to register for the program. You have to prove that you are a heroin addict. That's not too difficult for most people to be in the program. And you have to be at the program every morning by 8 a.m. to get your dose of methadone. The idea is that a person can use methadone and have a full-time job. Okay? It's very annoying to have to be someplace at 8 o'clock every morning, including on the weekend, because if you don't come in, you're going to have withdrawal symptoms. One of the things that's done in a methadone maintenance program is that urine tests are done at random, so the patient doesn't know when they're going to have a urine test. And the idea is we see if they're using any drugs other than methadone. If they may be using heroin or cocaine, that is not allowed in a methadone maintenance program. Now, they don't get removed from the program when they use heroin or another drug, but they lose some of the privileges that they have gained by being in the program. And one of the privileges you gain by being in the program is that you get to take a pill home once a week after you've been in the program for a few weeks. So you may not have to wake up early in the morning on Sunday or Saturday or Friday, okay? Instead, you can sleep late and take a pill. If you are found to be using another drug, you lose your privilege. You lose your day off, and you have to start coming in again 7 days a week. Okay. Now, buprenorphine is a new management which is available for maintaining heroin addicts and can be prescribed by primary care physicians in their private practice. So this is the first time primary care physicians can manage heroin addicts from a private practice. So buprenorphine comes all by itself. Buprenorphine, the trade names are in parentheses. You don't need to know them for the boards. Buprenorphine plus naloxone is used for people who might try to use heroin along with the buprenorphine, and naloxone will block opiate receptors for heroin, but not for buprenorphine. Okay. So buprenorphine alone or with naloxone, prescribed by the doctor, but the doctor must have a one-day course and certification in prescribing buprenorphine. Okay. Let's just see where we are, my friends. Okay, that's our last group. Let us now take a break. We'll take a 10-minute break. I'll see you in 10 minutes. Or anyway, you'll hear me in 10 minutes. Let's go. Okay, now so exciting. The next group of drugs are the hallucinogenic drugs, which some of them are frankly hallucinogenic, others have similar effects. LSD, of course, is the classic hallucinogenic drug. It works through the serotonin system. PCP is another drug that was originally a veterinary anesthetic, and it now is used also to produce unusual experiences. Marijuana, this is a very interesting story in the United States. We don't have time to go into the whole story about marijuana, but marijuana is legal in some of the states in the United States. Not only for medical use, but also now for recreational use. And the state of Colorado was the first to allow recreational marijuana. And so it can be sold pretty much like alcohol. It's sold, though, only in certain places, certain stores. And the prices are regulated by the state government. Okay. Intoxication with hallucinogens leads to psychotic symptoms like hallucinations, and the idea is that the person is supposed to have an interesting out-of-body or hallucinogenic experience. So it's used particularly by younger populations. Pupil dilation we see in LSD, and abnormal eye movements, that is a hallmark of PCP intoxication. So abnormal eye movements and violent behavior are both characteristic of PCP. There are no withdrawal symptoms. The drugs do tend to last a long time. So the management of patients who are intoxicated is to keep them calm, keep talking to them, use antipsychotics if they do have frightening hallucinations until the drugs wear off. Okay. Yes, the state of Faisal, the state of Colorado. Okay, that's in the West. Okay, and a number of the Western states tend to be more free with respect to drugs and things like that. The state of Washington, the state of Oregon, the state of California. Okay. Okay, well, look at this guy, everybody. Now, you don't look like this from exercise alone. Okay, you cannot look like this from exercise alone. This is a picture of somebody who's using steroids for to increase musculature, but steroids also have behavioral effects. Steroids cause mood changeability and can even cause psychotic symptoms. So when you see someone who is an athlete and built up like this, okay, in the emergency room with psychotic symptoms or significant mood symptoms for no apparent reason, we have to think in terms of, is this a steroid abuser? Okay. Okay, now doctors tend to think that all substance abusers are young men, okay, and therefore substance abuse may not be identified in women, for example, or in older people, higher socioeconomic status patients, because we expect it to be in young men and typically in the poorer populations. Illicit drug users can be employed full-time because they may only use the drug when they are not at work. And very often their home life suffers and their legal status suffers because they've been arrested for drunk driving or driving under the influence, DUI, before their job is affected. Okay. Okay, what about the substance abusing physicians? And these questions are on the boards very commonly. What is your responsibility when you think that another physician is using substances while seeing patients? That is, the other physician is impaired somehow. There are other causes of physician impairment besides substance abuse. There are things like old age and infirmities associated with old age, with an ill physician who will not stop seeing patients but is impaired. It is your responsibility as a physician in the U.S. to report that individual to whoever is in charge of that person. So if it is a physician in private practice, you will be reporting to the state licensing board. That is the medical licensing board of the state that you are practicing in the U.S. Okay. If it is a resident that is impaired, you report to the director of residency training. Okay. If it is a medical student that's impaired, you report to the dean or the administration of the medical school. So whoever is in charge of that person. So you must report. You report to the person in charge of that person. You only report to the state licensing board if the person is in private practice. You must get the colleague to suspend patient contact immediately. That is, the doctor cannot see even one more patient, and ideally make recommendations to the doctor. Now, in every state in the United States, there is an organization formed by physicians to help other impaired physicians. And that is the organization that you will contact before you contact the State Board of Medical Examiners. Okay. The State Board of Medical Examiners only gets involved if the physician's assistant program, or whatever it's called in that state, made up of physicians, cannot manage the case. So what the physician support group will tell that doctor is, you must go into treatment or we will report you to the State Board of Medical Examiners. Okay. And the colleague then, therefore, will go into treatment and be subject to regular drug testing. So people will come and take urine samples at odd times from the state organization of doctors that deals with that. Okay. Let's take a look at this very typical board question. At an evening going away party for a nurse, a 40-year-old physician drinks 10 glasses of beer. The physician then gets a page to go to the hospital. Despite the fact that a colleague tells him not to go, the doctor says, "I'm fine," and leaves for the hospital. What is the most appropriate action for the colleague to take? Okay. Follow the doctor and physically restrain him. Immediately notify those in charge at the hospital that he's likely to be impaired. Report him to the hospital ethics committee the next day. Report the doctor to the State Board of Medical Examiners as soon as possible, or ask to speak to the physician alone as soon as possible. Okay, my friends, you have 30 seconds to answer the question. I'm going to give you a little bit extra time. We started the timer. It's okay. Okay, so what should you do? I think you're doing pretty well on this question. Okay. Very good. 76% of you got it right. The answer is B. Immediately notify those in charge at the hospital that the doctor is likely to be impaired. We don't physically restrain the doctor because physicians come in all sizes. This might be a great big physician who's drunk, and you may be a little tiny doctor. Okay? So, we notify those in charge at the hospital so that the physician does not see even one more patient. Okay, my friends. Okay, now we're going to talk about human sexuality and concentrating on what the boards asks about. The boards can be quite graphic in their questions. Remember, in the United States, people are told to talk about their sex lives to physicians, ask doctors about sexual problems. So it is the physician that deals with the sexual problems of patients, and physicians have to educate themselves to some extent in this area. Most medical schools will cover human sexuality. Students from other countries may not have had an education in this area, but I will note here that it is the business of the primary care physician to deal with sexual problems in patients. You do not refer patients to sex therapists. You, as the primary care doctor, answer the questions and make suggestions for management. Okay? So no matter whether the patient is male or female, and no matter whether or not you are male or female, it's irrelevant. Okay? It's irrelevant whether the patient is gay or straight. You will manage the sexual problems of gay people as well as straight people. Okay. Remember a couple of things about the United States culture, and that is that sexual intercourse before marriage is the norm. Most people in the United States, men and women, have sex before marriage. Okay. The average age of first sexual experience is age 16 years for men and women. Adolescents tend to have one partner at a time. We call that being serially monogamous. They ask on the boards, by the way, these little stars are reminding me of board questions when you see the asterisk. The hatch at the end of the slides is just showing me that it's the end of the slide. It doesn't have any special meaning. Okay, sometimes students ask me that. Okay, so you are going to manage the sexual questions of adolescents as well. Masturbation is normal. It is ubiquitous. That is, it is very, very common. Everyone at some point in time has had experiences with masturbation. It is considered normal behavior, and the usual response to adolescents who ask questions like this is, reassure them that the behavior is normal. Okay, the behavior is normal. Now, the thing that we look for in adolescence in general, not only with respect to sexual behavior, but children and adolescents, we want to know, are they doing well in school? And kids who are doing well in school do not have any psychopathology or sexual behavior problems or substance abuse. So if the kid is doing well in school, that is a normal kid, okay? Very often in the United States, adolescents have difficulty with their parents during the teenage years. They may argue with their parents. They may do some things which get the parents angry. However, as long as the adolescent is doing well in school, they do not have a problem. Okay, so that's the whole key, is doing well in school. Okay. Just check and writing a note for myself. Okay. Okay. Okay, so about 1 million U.S. teenagers get pregnant every year. About 10% of teenage girls, so sex is the norm before marriage. Teenagers sometimes use contraceptives, sometimes they don't. Okay. Okay, so we have one question here. Let's see. Haya is asking question. If intercourse by 18, then how is it possible to allow contraceptive use at 15? Well, 15, obviously it occurs by 18. You want to allow contraceptive use before that, before it actually happens. Okay? Okay, so contraceptives, you can prescribe, as a physician in the United States, contraceptives for teenagers starting at age 14. Okay, Haya? Starting at age 14. It's not uncommon to see pregnant 14-year-olds in the United States, or even younger. Okay? So a doctor can prescribe contraceptives for teenagers without parental consent or notification in the U.S. You can treat a teenager's sexually transmitted disease without parental notification or consent. And you can even give her medical care in pregnancy without consent. Okay, my friends. Okay. And of course, being a teenage mother limits your choices. School dropout is common in teenagers. They are also at higher risk for obstetrical complications because of the immaturity, physical immaturity. And children of teenage mothers are more likely to die or have health problems. Okay. Again, because teenagers really rarely seek prenatal care and very often just come to the hospital to deliver the baby because they don't want other people to know that they're pregnant. Also, they cannot afford care. Okay. STDs in teenagers, the highest incidence, sexually transmitted diseases, not only in teenagers, but across the population. The new cases are chlamydia, primarily. Many people are infected with the herpes type 2 genital herpes virus. And many teenagers will have what we call an STD, a sexually transmitted disease, which can be managed by a physician without parental consent. Paraphilias are abnormal focuses of sexual behavior. That is, the focus of a person with a paraphilia, and it's almost always men, is on something other than an adult, living, consenting partner. The focus is on something else. Some of the paraphilias are dangerous, like this one. They look very innocent, but this can actually be damaging. You'll see these patients in the emergency rooms because they've been damaged by some of the practices they engage in. That's the sadomasochist, okay? Some of these are illegal. This one is not illegal, but it can be damaging physically. Illegal ones like pedophilia So pedophilia is the most common paraphilia. That is sexual interest in prepubescent children. And some pedophiles are particularly interested in very, very young children. A pedophile prefers children to adults, both men and women. So the pedophile is almost always a man, and his sexual interest is toward either male or female children. Okay. The exhibitionist is the person who exposes his genitals to women, and he typically does it in places where he cannot be caught by the police, because this is also illegal. The voyeur is watching other people while they're getting undressed or while they're having sex, and they don't know he's watching them. They often have cameras or binoculars to view people. That is his method of getting sexual satisfaction. The sadist and the masochist, again, not illegal if they have consenting partners, which they typically do. A fetishist is somebody who focuses on objects rather than people for sexual satisfaction. The objects can be things like rubber sheets. There are all kinds of different fetishists. Some men will be turned on sexually by wearing women's underclothing. That's the transvestic fetishist. These men are always heterosexual. That is, the clothing is a sexual exciter for a transvestic fetishist. That is, they're interested sexually in women. Nobody wears male clothing as a sexual turn-on. Okay, so this is always men wearing women's clothing. Okay, and typically women's underclothing. The frotteur is an illegal act. The man rubs up against women in crowded places where they cannot get away, like in a crowded bus or a subway or a train. Okay. Zoophilia is preferred sex with animals, and that is abnormal, and animals can really harm people. Some of these larger animals can cause some very unusual injuries you may see in the emergency room. There are other paraphilias. Some of them sound quite awful. There is necrophilia. That's a judgment. I guess I shouldn't do that. And if you see a patient in the emergency room who's engaging in one of these paraphilias, you have to be very cool and say, tell me more about that. Okay. And find out if it is endangering the patient in any way. If it is endangering the patient, then you make recommendations for safer practices. Okay. That is the way we manage the ones that are not illegal. Okay. Sex with cadavers, necrophilia. Hypoxiphilia is a dangerous paraphilia. This is where the individual uses some type of strangling technique to increase the sensation of sexuality, and they can actually kill themselves or kill their partner with this. Is necrophilia illegal? It probably is illegal, but it's more likely to be what we call a misdemeanor rather than a crime. That it is against the law, but it probably will not be punishable by jail time. Okay. Okay. Sexual development. Now, this individual is a man who has assumed the appearance of a woman. Okay. In this society, in the United States society, women look like this. Okay. Men don't look like this. This man is wearing makeup on his eyes. He's wearing lipstick. He has his hair in a way that a woman would wear it. So he has assumed a female gender role. That is, the gender role is the way you present yourself in society. Gender identity is your sense of whether or not you are male or female. Are you male, or do you feel like you are female? So your sexual identity is what sex you are, male or female. But gender identity is, how do you feel? Do you feel like you're male? Do you feel like you're female? If there is a discrepancy between your biological sex and your emotional sex, we would say you have gender dysphoria. That is a new term, DSM-5 term for gender identity disorder. Let me mention the DSM-5 since this is the first time that it came up. The Diagnostic and Statistical Manual of Mental Disorders is the classification scheme used in the United States for mental disorders. It is published by the American Psychiatric Association, which is an private organization made up of psychiatrists who pay their dues to the organization. They have publications, they put out journals and newsletters, and they also write the book, the DSM. And last May, in May 2013, the DSM-5 was shown to the public. It had been almost 20 years since the DSM-4 was published. Okay. The DSM-5 has changed some of the terminology. What do you need to know for the boards? They will ultimately require you to know DSM-5 terminology. Depending on when you are taking the boards, you need to start getting used to the new terminology. So we no longer have gender identity disorder, we have gender dysphoria. And I will point out throughout the lectures all of the new terms that you need to know. Up until now, the boards has told us that they will not grade any question that has the old terminology. So if they say gender identity disorder in a question, you can be sure that that question won't be graded as part of your exam. Okay. Okay, my friends, let's see. Questions? Okay, no questions. Okay, good. Let's take a look at this. Oh, okay, there's one other sexual development, and that is sexual preference. That is, do you prefer people of your sex or of the opposite sex for your relationships, for your sexual relationships, and for your long-term commitment relationships? Homosexual people prefer people of the same sex. Heterosexual people prefer people of the opposite sex. And this is for the boards. Remember that sexual preference, there is no sexual preference that is abnormal. All of them are normal. Whether you're heterosexual or homosexual, that is normal. Homosexuality does not appear in the DSM-5 anywhere. And it hasn't appeared in the DSM since 1980 when it was taken out. Okay. So homosexuality is normal in the U.S. Okay. And it is close to 10%, between 5 and 10% of the population. Okay. Now here there's a situation where the child's gender identity does not match his biological sex. Okay, so we have a little child who's 8 years old. The 8-year-old wants to play with girls. Now, 8-year-old kids, boys, don't like girls, and girls don't like boys at this age. They have no interest in each other. But this boy wants to play with the girls. He likes to dress up like a girl and says boys are dirty, girls have better stuff, and he likes dolls and wants to be called by a girl's name. What should the doctor advise the parents? Okay, my friends, so get ready for your... we're not going to turn the timer on now. I think I'll read the answers first. Suggest that they give the child a timeout when they see him playing with girls. Suggest they give him only trucks and action figures to play with. That's boys' toys. Suggest that they consider having a sex change operation for him. Teach the parents that it's okay for the child to play this way and help them accept the situation. Or inform the parents that the child will probably have a homosexual orientation in adulthood. Turn the timer. Okay, my friends, how are we doing on this question? Well, we have lots of attendees. We have 56 on our attendee list, and we have probably about 20 or 25 responses. So the rest of you, please respond. Take a chance. Okay? There's no penalty for guessing, and they say that on the USMLE, as I told you yesterday. Okay, my friends, very good. Let's see the answer. The answer is, and 57% of you got it, D. The current thinking on gender identity problems or gender dysphoria is to help the child and help the parents and the child accept the gender that the child believes that he is, because gender identity is cemented in by the age of 4 years and is unchangeable from then on. Okay, so we know that people with gender identity problems have high rates of suicidality in adulthood, even if they have gender-changing surgery. So the idea now is to help people around these kids get used to them the way they are and accept them as they are. And buy the clothing that they want, help them get a new name, a name change, have the teacher treat them as the opposite sex, or the sex that they believe they are. And that is the current thinking. Okay, my friends. So D is the correct answer. Okay. Any comments on that? Can I repeat that? Okay. Ibrahim is asking if I can repeat that. That is, when a child has gender dysphoria, which this child has, he believes that he is a girl. The management of gender dysphoria is to help the family members accept the child in his belief, in his new gender, because you cannot change gender identity. And the question is, won't that cause them more teasing at school? These children are teased relentlessly in school. It is a very difficult time growing up for them. Now, one of the reasons is that they're always trying to be like the gender that they think they're supposed to be. And the parents are trying to do that. Teachers are trying to make them change back. Okay? It is impossible. Okay? And if the parents and teacher are supportive of the child, the hope is that the child will have less problems in school, because they will play with the opposite sex and they will be comfortable with that sex. Okay. Okay. Now remember that nobody would do this. Nobody would choose to be the opposite sex if they could help it. It is a very difficult life, no matter what society you are in. Okay. Okay, sexual dysfunctions. Remember that your patients who are taking certain medications will have effects on their sexuality. The psychoactive medications alter neurotransmitters in the brain, and a number of these neurotransmitters are also involved with sexual functioning. Okay, so the antipsychotics block dopamine, and dopamine is the sex neurotransmitter. I mentioned that earlier. And so there's a decrease in sex drive and a decrease in sexual abilities. There are erectile dysfunction with the antipsychotics. Antipsychotics also cause elevation of prolactin. Dopamine, you'll remember, normally suppresses prolactin. So when we suppress dopamine, prolactin comes up. And that causes variety of problems like menstrual irregularities, sexual dysfunction, breast enlargement and secretion, etc. Okay. The beta blockers and a number of other antihypertensive medications affect norepinephrine systems, which also in turn affects sexuality and particularly causing erectile dysfunction in men. Cyclic antidepressants also can cause erectile dysfunction. Drugs that increase dopamine, they're the only aphrodisiacs, okay? They're the only drugs that potentially can increase sexual functioning. And the SSRIs all block reuptake of serotonin, causing more serotonin to be present in brain synapses and causing sexual difficulties. So serotonin is great for your mood, but it's very poor for your patient's sex life. Okay. So the SSRIs tend to inhibit orgasm in men and women. They tend to lead to persistent erection because they inhibit orgasm. They can lead to priapism, which is a persistent erection. Trazodone is a cyclic antidepressant, can do the same thing. That's notorious for causing persistent erections, which is a medical emergency, as you know. Now, patients are reluctant often to talk about sexual difficulties to doctors because it's embarrassing. So we always say to patients who say, patient may come to you and say, this was a board question, doctor, could you tell me again the side effects of the antihypertensive medication I'm taking? Okay. And that's because the patient's embarrassed to tell you that he's having sexual problems. To the patient, a lot of people have sexual problems with these drugs, which is true. Always tell the patient the truth. Tell me what's going on. Okay. Understanding often an issue for patients. There are a number of sexual dysfunctions in the DSM-5. Female sexual interest or arousal disorder is one of them. We know that hormones, after menopause, there are very little production of female hormones, which can lead to vaginal changes, which can lead to sexual problems. We have to evaluate hormonal state. We also have to evaluate over-the-counter medications, which can also cause vaginal dryness, like antihistamines and anticholinergics. Okay. In men, male erectile disorder is the most common of the male sexual dysfunctions. It gets more common as men get older. We always check for alcohol usage because alcohol use is the most common cause of erectile dysfunction in men of all ages. Diabetes is the most common disease causing erectile dysfunction in men. And the treatment of sexual dysfunction now, here are the little blue pills. This is Viagra. These drugs were originally, as you know, developed as antihypertensive medications, but in clinical trials, their erection potentiating potential was observed, and they decided, we're not going to use this as a antihypertensive, we're going to use this as a sexual erectile dysfunction drug. Okay. Okay, the orgasm disorders. Inhibited female orgasm is more common than in the male. But both of them are becoming more common with the use of SSRIs. Many people in the world, but in the United States population, are taking an SSRI. So inhibited orgasm is in men and in women is the one of the side effects of the SSRIs. And that's why the SSRIs are used to treat one of the male sexual dysfunctions called premature ejaculation, because they delay orgasm. Okay. Okay, so premature ejaculation is the most common orgasm disorder in men of all ages. The male feels like he has no control over the ejaculation, and the management is something called the squeeze technique, which is a behavioral treatment. We can also, as I mentioned, use SSRIs. But the behavioral treatments will trump over the medical treatments because they're safer. So the head of the penis is squeezed just prior to orgasm. The man learns to identify the point of orgasm. And this was on the boards, my friends. Who squeezed squeezes in the squeeze technique? The patient, the partner, the physician, the nurse, or the physical therapist? Please answer the question. Okay, open the poll. Please open the poll to allow for voting. Thank you. Okay, who squeezes in the squeeze technique? That's a strange question. I haven't heard about it again. I heard about it once, but I thought I'd put it up because it's an interesting question to say the least. And the answer may be even more interesting because the squeeze technique is administered by the partner, not the patient. The patient tells the partner when to administer the squeeze. The partner does it. The erection subsides and the patient gains more time. Okay. So the answer was was B. Oh, I almost got it wrong. I'm seeing that most of you chose B. The answer was B. Okay. It is the partner. Any questions on that? Okay. Okay, this is a new diagnosis, sexual pain penetration disorder. This is only diagnosed in women. That is pelvic pain with sexual activity that is not explained by pelvic pathology. So we must rule out, of course, for this particular disorder, any pelvic pathology that may be causing pain, because this is believed to be a psychological reaction to having been raped or having been sexually abused earlier in life. It can include a involuntary muscle constriction of the outer third of the vagina. This used to be called vaginismus. That term is not used anymore in the DSM-5, nor is dyspareunia. There's no more dyspareunia. This is now called sexual pain / penetration disorder. Okay. We talked a little bit about this already. This is normal activity, equally common masturbation in men and women. It's only abnormal if the individual does this at the expense of going to work. Okay. Otherwise, this is normal behavior. We reassure people this is normal behavior. Homosexuality, you'll remember, is also normal behavior. And the issue in homosexuality is not which sex you have sex with, but which one you would prefer to have sex with. And many homosexual people marry people of the opposite sex because that's expected of them. They often have children, but their preference is for people of their own sex. Homosexuality is completely biological. It is not caused by social factors at all. And the preference is well established by puberty and is unchangeable. In the United States, the American Psychiatric Association says that if a physician attempts, or a psychiatrist rather, attempts to change the sexual orientation of a patient, they are being unethical. It is considered unethical to try to change sexual orientation because it is such a permanent quality. Okay. Okay, one of the students is saying he's having trouble seeing the slide, so I don't know what the issue is, my TAs. Okay. That's Amani. Okay, let's do this question now. This is important, an important board question. Okay. A mother finds her 12-year-old son, and let's start the counter again, and let's start the clear the poll. Clear the poll. Okay, a mother finds her 12-year-old son in the shower with another 12-year-old boy and calls the doctor. The doctor should, and we can start the timer now. Okay. Ask her to come in with her son ASAP. Ask her to bring her son in and then let the doctor speak to him alone. Reassure the mother that this behavior is normal. Test the boy's androgen levels. Tell the mother that the boy will probably have a homosexual orientation in adulthood. Okay, my friends. What do you think? Oh, you guys you're right on target. You're right on target. Very nice. Okay, very nice. The answer is C, absolutely right. Reassure the mother that this behavior is normal. What's normal is that the children are the same age. That is normal behavior. Kids play these games, they play doctor, they practice with one another. This is normal behavior. Now, this mother called the doctor because she found her son in the shower with another boy. If she found her son in the shower with a 12-year-old girl, she wouldn't have called a physician. She might have spoken to the parents, she might have spoken to the kids, but she would not have called a doctor because she would not have thought that this was abnormal. Okay, it may not be desirable, but it's not abnormal. Okay, neither is this. Two boys is no less normal than a boy and a girl. Now, importantly, the children must be the same, approximately the same age, within a year or two, and that is normal. If the children are of grossly disparate ages, that is, a 12-year-old is in the shower with a 6-year-old, boy or girl, that is abnormal behavior. The 6-year-old is fondling a 2-year-old. That is abnormal behavior, okay? So if the ages are very different, that is the preschooler, that's before 6, with a school-age child, that's 6 to 12, or a school-age child with a teenager, that is abnormal. And it typically indicates that the older child has been sexually abused by an adult. So children who are sexually abused by an adult very often play these kinds of games with much younger children, sort of reenacting the thing that was done to them by an older person. Okay, so as long as they are the same age, it doesn't matter what gender they are, this is normal behavior. How are we doing, my friends? I know that this is difficult. In some cultures more than in others, but again, these are just the kind of questions that students who don't grow up in the United States culture have the most difficulty with. Okay. This is a difficult question. This one was just on the boards. Parents bring a 15-year-old boy to the doctor. They state that the teen, who's been developing normally, persistently masturbates in front of an unshaded window where others can see him during daytime hours. This is not normal behavior. This is not normal behavior. This boy is showing symptoms of exhibitionism. Remember the exhibitionist, exposing himself. What should the doctor do? Should the doctor reassure the parents? Recommend hormonal therapy? We're going to set the counter again. Recommend behavioral therapy, speak to the teen alone, or reassess the teen in 6 months, my friends. What is the answer here? The last one is E. Okay. What do we have here? Okay, so most of you picked behavioral therapy, but the first thing you want to do even before behavioral therapy is speak to the teenager alone. Okay. Speaking to the teenager alone will tell you what is going on and why he is doing this. Ultimately, we may use behavioral therapy, we may use hormonal therapy. That is, female hormones are not uncommonly used for the sexual paraphilias. However, first we speak to the teen alone. Anything that has to do with sex or drugs, we speak to the teenager alone. Okay, my friends. We're going to go just a little bit over because we did lose our picture for a while. Let's just do one or two more slides. Okay. Sexuality and aging. Remember that in the United States, sexuality is expected to continue from teenage years into old age. And the best predictor of whether older people will have sexual activity is, do they have a partner? And very often women do not have a partner because men die about 7 years earlier than women. So old people are still interested in romantic attachments in the United States. Okay. Changes, though, occur with aging. In men, a slower erection, a longer refractory period after orgasm until restimulation is possible. A more direct stimulation is needed rather than psychological stimulation. And in women, there are vaginal changes that are associated with menopause, associated with the lack of estrogen production. We used to treat this fairly easily with estrogen replacement therapy. That is rarely used anymore because of the propensity of estrogen to cause breast cancer and uterine cancer. Okay, so yes, so we don't recommend estrogen as often as we did. So we use a local application of a moisturizing agent rather than estrogen. Okay. Okay, so no matter how old the patient, you're going to evaluate the patient for sexual difficulties, for medical problems like diabetes, even if he is 95 years old. Okay, my friends, I hope you got the point. Let's look at this question. A couple in their mid-20s who've been married for 3 years. This is our last slide on this, and then we're going to take a break. They've been married for 3 years. They come to the doctor for a fertility evaluation. The wife says, "I don't understand why I can't get pregnant. We have sexual relations 3 times a week for the past 2 years. What is the most appropriate step for the doctor to take next?" Refer them for marital counseling. Perform a gynecological exam on the wife. Suggest they both undergo fertility evaluation. Ask the couple what they mean by sexual relations, and reassure them that sometimes it takes more than 2 years to get pregnant. Okay, my friends. What is the answer to this board question? See how we're doing here. Let's see. I'm looking at the counter. And I see that 73% of you got it right. And that was D. Ask the couple what they mean by sexual relations. Not everybody knows what it takes to make a baby. And some people who have been quite sheltered may not know what sexual relations actually involve. And you, as the primary care doctor, are going to be providing the instructions, the literature, books, things for them to read, as well as talking to the patients. Okay, so on that note, we're going to take a 10-minute break. uh, um, other problems that people have, diet, inactivity, etc. One way that doctors help patients, of course, is by teaching them new health behaviors. And to do that, we use some of the theories of learning, of how people learn in the first place. Now, this chapter, chapter 6, also gives us a foundation to understand, help people with emotional problems and behavioral problems. You will jump, or you will shriek, or you will scream if you don't try to stop yourself. Okay? And little kids don't try to stop themselves. So when the kid gets the injection, the kid will cry. The injection is an unconditioned stimulus. It produces the crying response. Now, the child may then make an erroneous association between the injection and these gloves that the nurse is wearing. And from now on, the child may become frightened of that color of blue. Okay? So either the doctor or the color of blue or the nurse becomes associated with pain and becomes the conditioned stimulus. So every time the child sees the blue gloves or the clothing that this person is wearing, the child starts to cry by stimulus generalization. Okay? The sight of the needle. That's another one, absolutely. But even if the child doesn't see the needle, and those of you with children or have been around a lot of children know that even when the child approaches the place where the doctor is, the child starts to cry. Okay. Let's look at this board question. A patient with hypertension is put on new medication and instructed to take his blood pressure at home. He says that it's normal at home, but in the doctor's office his blood pressure is high. What is the most likely reason for this? He is non-adherent with his medication. The blood pressure machine that he has at home is faulty. It is an iatrogenic effect of the doctor, that it is caused by the doctor. He is not truthful about his blood pressure at home. Okay, my friends. Put your questions in. We've started the counter. Very nice. Very, very nice. Okay. Yes. And the answer is C. It is an iatrogenic effect of the doctor. That is, the doctor has caused this patient to have a sympathetic response. Patient automatically has a sympathetic response to the doctor, and his blood pressure goes up, and we do call that white coat syndrome or white coat hypertension. Okay. And the doctor becomes the conditioned stimulus. Absolutely right, Ahmed. Very good. Okay. The doctor or the lab coat becomes the conditioned stimulus, and the patient responds. The sympathetic nervous system responds. The patient may or may not be aware of his fear consciously, but his blood pressure certainly knows that he's in a dangerous situation. Okay. Now remember here, with respect to answer D, patients do not lie to doctors. The only patients who lie to doctors are those that are involved with the legal system. We've talked about this. So patients do not lie to doctors because they're afraid if they lie to a doctor, the doctor won't do the right thing and they'll die as a result. So patients don't lie to doctors. Okay. except for the criminals. Okay. Okay, now operant conditioning. So that was classical conditioning. That was learning by association. The patient associated the doctor or the white coat of the doctor with negative things, and the patient had an automatic response. So it was actually caused by learning. Okay. One of the things that we would do to help this patient not have this response to the doctor, associate the doctor with something good. Okay. So when the patient next comes in, the doctor will talk to the patient, try to relax the patient, get to know the patient a little bit, and the patient then is less likely to have this reaction, okay? Because the doctor has made the patient comfortable, and the patient now associates the doctor with relaxation and comfort rather than fear, okay? So the patient has been desensitized. We have exposed him to doctor, but we've done it in association with relaxation, and now he associates the doctor with relaxation rather than with fear. Okay, and that treatment technique where we gradually expose a patient to increasing doses of something scary, does anybody know what that's called? When we put the person in a relaxed condition and then expose them slowly to something frightening? My friends? I see some of you are typing, so I'll just wait a minute and see if you've got it. Well, it is a kind of training, but it has a name. Yes, Amir, very good. That is desensitization, systematic desensitization. Right, systematic desensitization is when you do it gradually. But desensitization is exposure. Ultimately, the patient will stop showing the response. Very nice, very nice. Okay, now we're going to look at operant conditioning. It's also called instrumental conditioning. And where classical conditioning was learning by association, operant conditioning is learning by the consequences of a behavior. That is, you learn by what the behavior that you have shown at random has gotten you. If the behavior that you have shown has gotten you something that you need or want, that increases your behavior, okay? And that thing that you want is called positive reinforcement. Okay, so let's take a look at this hungry pigeon who's in a box that was developed by B.F. Skinner, and you never need to know the names of any of the developmental theorists or any of the theorists. The board does not care about that. You don't have to know those names. But he did describe this paradigm or this situation. He put the pigeon in a box, and the pigeon was hungry. You have to have a motivated bird, okay, or motivated person for operant conditioning. And what do birds do when they're very hungry? They start to put their beak to everything around them. They peck at everything. And he was pecking away at all the different sides of the cage, and the back of the cage, and the floor of the cage. And when he pecked on this side of the cage, he got a piece of food in the food box. The food box is right here. If the pigeon pecked here, he didn't get anything. Here, he didn't get anything. Here, he didn't get anything. Here, he got food. So the consequences of a behavior that he emitted at random, the pecking behavior, got him something. Pecking behavior only on this side of the cage. Okay? Eventually, we reward him only for pecking close to the food cup. And finally, he only gets rewarded when he pecks right on it. Okay. We have shaped his behavior. That is, we have taught him to peck on this spot on the cage by rewarding him for doing it. Okay. And that is called positive reinforcement. Okay. So he has learned by positive reinforcement. So let's think of this example. You have a little kid, and he keeps hitting his little brother. He's just smacking that little brother around, okay? Every time he smacks his brother, his mother screams at him, "Don't do that." Turns her back, and he smacks the baby again. What has he gotten for his hitting the baby behavior that would cause him to continue showing that behavior? What has he gotten? That's right, he's gotten attention. And we know that he's gotten something, we know he's gotten positive reinforcement because he keeps on hitting his brother. So sometimes the behavior, or whatever is causing the behavior to increase, may not be so obvious, okay? But if the behavior does continue, we know that it has been positively reinforced. That is, if the behavior continues. And this little kid is continuing to hit his little brother, therefore we know he has gotten some reward for it, and we assume it is attention. Okay, so let's look at the 4 elements of operant conditioning: punishment, extinction, positive and negative reinforcement. Behavior stops after something is emitted, that is, the behavior that you do not want stops completely. We know that the individual has either been punished or the behavior has become extinct by non-reinforcement. Okay. If the behavior continues, there is positive reinforcement or negative reinforcement. Now let's look at the stimulus difference. Okay. We add a stimulus, the child stops hitting his little brother. Okay, so we do something, perhaps the mother smacks the child on the hand, and he stops hitting his little brother. When we look at those 2 things, we know that the child has been punished. Okay? If we hit the child and his behavior continues, we know that he has gotten positive reinforcement. That's right. So we add a stimulus. Does the behavior stop or does it continue? That will tell us whether it is punishment or positive reinforcement. Remove a stimulus. Stop rewarding the child for his hitting his brother behavior, and his behavior stops. So he stops hitting his little brother because the mother has stopped paying attention to it. The behavior has disappeared by reinforcement, okay? Because the behavior, hitting the little brother behavior, has stopped. If the mother says, if you continue hitting your little brother, I'm going to take away your television set, and a lot of American children have television sets, okay? The child stops hitting his little brother, okay, in order to avoid losing his television, okay? So whenever we have avoidance in the paradigm, and the behavior which we want is continuing, that is, his good behavior continues, that is negative reinforcement. This is the most difficult concept of the 4 of them, and we're going to go over lots and lots of questions about this, okay? So the first thing to look at, is the behavior continuing or is it stopping? Okay, so let's take a look at some questions now that we know that. Okay, so let's take a look at this. Rather than answering the phone, a girl begins ignoring a boy who calls for dates. Okay, so the boy calls to talk to the girl and to ask her to go out with him. And eventually he stops calling. So she stops answering the phone and he stops calling. His behavior is based on, that is, his change in behavior is based on positive reinforcement, negative reinforcement, punishment, or extinction. Why has he stopped calling? Okay, behavior has stopped. That's going to give you a clue. Okay, my friends, very nice. We are out of time, and what the answer is extinction is correct. She has stopped rewarding him by paying attention to him, and his his behavior has become extinct because it is not rewarded. Okay, we will get to the difference between punishment is when you add something, okay, and behavior stops, like a smack on the hand. Here, when you stop the stimulus and the behavior stops, okay, that's the difference. Here you add a stimulus, here you remove a stimulus and the behavior stops. Okay. Okay, let's try this one. Praising students for questions causes the students to ask more questions. Okay, we can start the timer. The counter. Okay, we're going to cut it a little bit short here because you've stopped clicking in. And this is positive reinforcement. Behavior has increased or continued because it has been rewarded in the past. That is positive reinforcement. Okay, Abdulaziz, please tell me why you think that's negative reinforcement, my friend. Why do you think that that's negative reinforcement? Negative reinforcement is when you remove a stimulus and the students ask more questions. Okay? Okay, so this is positive reinforcement. We're adding a stimulus and the students are asking more questions. Okay. Abdulaziz, you meant the previous question. Okay, let's take a look at the previous question. And you're saying this is not negative reinforcement because she's not doing anything at all. She is just not doing anything. She is ignoring him and his behavior disappears, and that is extinction. Okay. Let's go through some more of them, okay, and then we'll go back if you have any problems. Okay, a patient is exercising on her treadmill. When she exercises, she gets terrible leg cramps, so she stops exercising. Her decreased exercise behavior is a result of what? She has decreased her behavior. That's a clue. Okay. Is it because you've added something or taken something away? Okay, we have decreasing behavior, so we know it's not reinforcement if behavior is decreasing. We know it's not reinforcement. Okay, the answer is this is punishment. Pain makes her stop. Pain makes her stop, that is punishment. Now, if she was a sadist, remember the sadist liked punishment, her behavior would increase. Okay, the more pain she had, the more she would increase. And that's a joke, my friends. Okay. Okay, but here, for most people, pain is punishment and the behavior goes away. Okay, so that is punishment. C was the answer and 55% of you got it right. Let's try this one. Shouting, "Be quiet," silences a child. What is this one? 30 seconds, please. Okay. Okay, Faisal, you're saying negative equals taking something away. Reinforcement equals increasing behavior. Right. Negative reinforcement, removal of a negative stimulus to increase behavior. Excellent. Very good. That's right, Faisal. Very good. It's a difficult concept, though, for lots of people. Okay, be quiet. The child, shut up. What is the answer to this? This is punishment. Because the child stopped talking. Okay. Now, what if the child had started screaming really louder every time you said be quiet? What would that have been? What would shouting have been then? Shouting would have been positive reinforcement if it caused the behavior to increase. That's right. But it's punishment because it caused the behavior to decrease. Okay. When a patient exercises, she can decrease the number of insulin injections she must take daily. So this is a patient who has to take 3 insulin injections a day, but if she exercises for 45 minutes a day, she only needs to take 2 insulin injections. So she increases her time spent exercising due to what? Start the timer. This is a little bit harder. And click in. Okay, we have a toss-up here, and A looks like it's winning. She's not getting anything for her exercising behavior, but she certainly is avoiding something negative. That's right, she's removing the injections. So her increased exercising behavior is due to negative reinforcement. Those of you who picked negative reinforcement got that one right. And in general, compliance with medical recommendations are all related to negative reinforcement. A person stops smoking to avoid lung cancer. A person diets to avoid heart failure, heart attack, okay? People follow recommendations to avoid illness in the future. Sometimes they get some added benefits which provide positive reinforcement, like everybody says you look terrific when they lose weight, but they do it primarily to avoid illness in the future. Okay? So this is a good example of negative reinforcement, that is increasing good health behavior to avoid something negative. Okay? Good. Let's look at this one. How about this one? This was a board question. A man is speeding down the highway in his car. He stops speeding after he sees another motorist getting a speeding ticket. Now, he doesn't get a ticket. His improved law-abiding behavior, that is, he stopped speeding, and they tell you in the question, his improved law-abiding behavior is a result of what? And they're asking you, what is this a result of? Positive reinforcement, negative reinforcement, punishment, or extinction? You can start the timer, my friends. Let's clear the counter. Okay, let's start again. I'm going to ask you all to start again. You have to be sure we clear the counter after each question. We have a number more questions. Okay. Okay, now so he is increasing his law-abiding behavior. The question tells you that, okay? So it must be reinforcement, okay? And some of you may argue, well, he stopped speeding. Yes, but the question specifically says his improved law-abiding behavior is a result of, and the answer is negative reinforcement, okay? He is showing good behavior to avoid getting a ticket himself, okay? Now, a number of you picked, some of you changed your answer since I saw it last. A number of you picked punishment. Okay, he is not getting punished. How do we know that? Because nobody did anything to him, okay? It was the other motorist that was getting the speeding ticket. Okay, his behavior improved. That is what's meant by negative reinforcement. It means behavior increases to avoid a negative stimulus. Ibrahim. Okay. Okay, so positive reinforcement, behavior increases as a result of something that is construed as being positive by the person. It may be attention, it may be money, it may be candy. Okay. Negative reinforcement behavior increases to avoid something negative. Punishment and extinction behavior decreases in both. Punishment behavior decreases as a result of a stimulus. Extinction behavior decreases as a result of not getting a stimulus. Okay, good. What is the stimulus in this question? Amir is asking me. What is the stimulus? The stimulus is the other motorist getting a speeding ticket. He is avoiding that stimulus. He is avoiding a speeding ticket. Okay. Okay, and Amani, I'd like to repeat it, but I don't know which statement I made that you would like me to repeat. So if you just give me an idea, I'll be able to do it. Okay. Okay, let's try another one. Are you up for that? I hope so. Okay, we'll go back to the definitions, Amani. Well, what we'll do is we'll go back to that little table that we saw. Okay? Okay. I will repeat all four. A number of you would like me to repeat all four. Let's go back to the table for now. Ooh, we did a lot of questions. This little table. Remember to look first at whether the behavior, the desirable behavior, is stopping or it's continuing. Okay? And whether a stimulus has been added or a stimulus has been removed. Okay? So we add a stimulus and the patient stops exercising. We added pain and the patient stopped using her treadmill. That is punishment. Okay? If we added pain and her behavior had continued, we know that the pain was a reinforcement. It was a positive reinforcer. Even though we think it's bad, if her behavior continued. The concept behind all of this is that people, animals, do not emit behavior for nothing. That they're always getting something for their behavior. And if behavior continues, something is being obtained by the behavior. Okay. When we remove a stimulus, we remove the attention that the child is getting from his mother, his behavior stops. We stop answering the phone when the boy is calling, and his behavior stops. And that is called extinction. In negative reinforcement, behavior increases or continues in order to remove a negative stimulus. So we go a little backwards here. That is, behavior continues in order to remove a negative stimulus. That is, you exercise more to remove the likelihood that you're going to have heart disease, or you exercise more in order to remove the possibility that you need more insulin injections, and that is negative reinforcement. Okay, my friends, so let's keep on going. I guess we can do these again. Shall we do that? Okay, so rather than answering the phone, we're going to just give you a couple of seconds on these. Let's clear it. A girl begins ignoring a boy who asks for dates, and eventually he stops calling. Which one is this? He stopped calling. He stopped calling, and the answer is D, right? No, it's not D, is it? It's not C, is it? It is D. That is correct. It is extinction. Good. She stopped rewarding him, and his behavior went away. Okay, so she removed the stimulus. His behavior stopped. We know that that is extinction. I praise you for your questions, and that makes you ask more questions. Which one is this? Very good. This is positive reinforcement. Let's go back. I have given you something. I have added something, and your behavior has continued. I have added something. What have I added? Praise. Your behavior continues. We know that that is positive reinforcement. Okay. If I praised you and you were a very, very shy person and you didn't want to be noticed at all, like a teenager, and you stopped doing whatever it was you were doing, we would know that that would be punishment. Okay? Okay, now we have a patient is exercising. The exercise causes pain, so the patient stops exercising. Decreased exercise behavior is a result of, click in, my friends. Let's go back. We'll take a look. Okay, the stimulus is pain. We have added a stimulus, and the behavior has stopped. That is punishment. Okay. Another one. Shouting, be quiet. Silence is a child. Clear the counter and start it again, please. To clear it after each question. Thank you, my TA. Okay. Shouting, be quiet, and the child stops talking. Excellent. That is punishment. Very good. Okay, here we have the patient exercising. She can decrease the number of insulin injections she must take daily. Her increased behavior is due to... Excellent, excellent. Very good. That is negative reinforcement. She's increasing her behavior to avoid something negative, the injection. Here's also negative reinforcement. The motorist stops speeding after he sees another motorist getting a speeding ticket. Okay, let's try this one. This is a new one. Okay, let's clear. Good. A child cries when mom tries to leave him. So she's leaving him with somebody else. She's leaving him with a babysitter. So she stays with him longer. So now he cries and cries and cries, and she stays with him longer and longer. Why has his behavior, his crying, increased? My friends, let's give this one a try. His increased crying behavior, so his behavior is increasing, is a result of, very nice, that is positive reinforcement. That is correct. Her staying with him longer has given him positive reinforcement. How do we know that? Because he's crying more and more. He cries, she comes back. He cries, she comes back. What about her behavior? What is her increase coming back to him or staying with him longer behavior a result of? Why is she staying with him longer and longer? Result of what? She's increasing her behavior, staying with him longer. Why? Why is she staying with him longer? Oh, I see some of you are getting it. Very good. She's not getting anything for staying with him longer, but she's certainly avoiding the screams. And that is negative reinforcement. She's staying with him longer to avoid the negative stimulus. Okay. Why is it not negative reinforcement to avoid the mother separation? Well, here we're asking why what the mother's behavior is related to. She would like to go shopping. She would like to go off and do whatever she has to do. But the screaming is bringing her back. So the screaming, in order to stop the screaming, she comes back to him. And that is negative reinforcement. To avoid having him cry, right. Avoid having him scream, Haya, you're right. So some of you are getting it a little bit now, I hope. Okay. How about this one? And we all experienced this. After being woken by the alarm clock 2 mornings in a row, on the 3rd morning, the student wakes up and turns off the alarm clock before it rings. This student's early waking up behavior is a result of what? Oh my goodness, you guys are getting it. You guys are getting it. I am so proud. Very proud. Okay. Excellent, excellent. This is negative reinforcement. You wake up to avoid that alarm. And your waking up behavior is improving in the morning, just in order to avoid that terrible noise of the alarm. Okay? That's negative reinforcement. Very, very nice. Very, very nice. Most of you got that. Okay, what we're going to do is we're going to take a break now. We're going to take our last break of the morning because we're going to end on the next hour. Okay? So let us now take a break. Welcome back everyone. Now I'm going to talk a few minutes about continuous versus intermittent or variable reinforcement. If you reward a child every single time he does something good, if you stop rewarding him, his behavior is going to disappear very quickly. Okay? So continuous reinforcement is getting a reward every time you do the required thing. Makes learning very quick. Okay? Learning is very easy, but extinction is all. That is, if you do, the individual disappears very quickly. Think in terms of a vending machine. When you put $1 into a vending machine, you always expect to get something out of it. Okay? If you put $1 in and you don't get anything out, you don't continue to put dollars into it, do you? Okay? The extinction in behavior, or whatever your monetary is that you have to put in a vending machine, you will stop doing it. Okay. If you are playing a slot machine, and in places where there is gambling, there are slot machines, gambling operations are based on reinforcement. That is, you never know whether or not you're going to get something back. Now, learning takes longer when you never get a reward. It's long if you reward every time he's up off the floor, but only sometimes. If you don't give him a reward, his behavior will continue for a long time. So intermittent or variable reinforcement extinction is much harder. And that's what, here I have a slot machine, that's what gambling operations are based on. They're based on very intermittent, it's the same thing, variable intermittent reinforcement. That is, you never know when your reward is coming. Continuous reinforcement, you get a reward every time you do something. In fixed, you get a reward every certain number of times you do something. For example, you don't get paid until you make 3 shirts. You make 3 shirts and you get paid. You have to make 3 to get paid. Making 1 won't get anything for you. So you're on what we call a fixed reinforcement schedule. That is, you have to make 3 and then you get paid. Continuous, you would get paid for every shirt. Variable reinforcement, you don't know how many shirts you have to make before you get paid. Okay, my friends? Okay, good. When a child misbehaves, his parents sometimes scold him and sometimes hug him. His bad behavior continues because it has been rewarded on which schedule of reinforcement, my friends? Start the timer. Okay, what is the schedule of reinforcement that's being used here? Okay, doing well on this one. Okay. Excellent. The answer is C. And this child has been rewarded or reinforced, sometimes he never knows what's going to happen. And that's why we say to parents, be consistent in your discipline of children, okay? Make sure that if you are disciplining a child, you'll do it every time they show the bad behavior, and reward a child as much as you possibly can as well. A mother had been giving a child a gift for each good school performance. When she stopped giving him gifts, his performance got bad again. What reinforcement was she first using to improve his school performance? What type of reinforcement was she first using? Okay, and remember that's right, that this is continuous reinforcement. That is, every time he did well in school, he got a gift. Now she stopped giving him gifts. His behavior was not resistant to extinction. It disappeared almost immediately because it had been rewarded every single time. Okay, so what are the clinical applications of this? And we talked about systematic desensitization already. That is, you have an individual who has an unrealistic fear of, let us say, cats. He's unrealistically afraid of cats. Now, why is he afraid of cats? We don't know, okay? It may have been that in the past he made an erroneous association between cats and something bad happens. He might have been playing with a cat when something fell on his head and injured him. And he said, he makes an association, cat, pain. And from then on, he's afraid of cats. The cat may have done absolutely nothing, okay, to him. So how do we treat that? Well, we teach him relaxation techniques, and then we gradually expose him to little bits or doses of the cat. We show him a picture of a small cat while he's feeling really relaxed and good. We gradually increase to a toy cat. Finally, a small real cat. And ultimately, a great big cat, okay? So he practices relaxation, and then he learns to associate cat with relaxation and comfort, and he's no longer afraid of cats. We don't try to look into the past as to what happened when he was a little kid, why he's afraid of cats. That'll come in the next chapter when we talk about Freud and his theories of the unconscious. Now, all we do is we teach him a new response to cats. Okay. And that's called systematic desensitization, and it's used to treat phobias, which are irrational fears. Another thing we can do to treat phobias is to overexpose the individual to the frightened stimulus until they're not afraid anymore. We desensitize them all at once. Okay. So we put this kid into a room full of big cats, not tigers and lions, but cats that won't hurt him, but that are walking all around him. Okay. Now, if he agrees to do that, we know that we're halfway home with his phobia. He's not as frightened as he was. Here's an example, a child who is afraid of dirt, who is very fearful of getting anything on their hands. And there are some, believe it or not, there are some children like that. Most children love to get dirty, but some children are very finicky. They don't want to be around dirt. So what we do with that kid is we wash our hands with the soap, and then we give it to him. So it's dirty by the time it gets to him. So we continue to wash and wash and wash with somebody else's soap until he is not afraid anymore. So this is called flooding if we actually do it. It's instructed to stand at the top of a tall building and look over the side. Or that treatment technique is called flooding. What you're doing, if you try that one on somebody who has a phobia. Implosion is imagine yourself in a room full of cats. You don't have to actually do it like you do in flooding, but you imagine it in implosion. Okay, based on operant conditioning, we have shaping behavior. That is, we reward for summations of the behavior. Remember that we rewarded the bird where we ultimately wanted him to peck. Even if he pecked on the side of the cage, he got a reward, and we shaped his behavior until it was perfect. Extinction, figure out what the reward is and eliminate the reinforcement. The child is getting rewarded for attention. Stop paying attention to him when he does that bad thing, and his behavior will disappear by non-reinforcement. Okay, and that's called extinction. This is a little biofeedback device. What this device is doing is it's measuring this person's finger temperature, okay, in Fahrenheit. Okay. This person is trying to learn to raise his finger temperature using mental techniques. And biofeedback uses that ability that we do have to alter physiological function by mental techniques. It works as long as you can measure the physiological function and get some positive reinforcement that your techniques are working. So imagine if right now we all thought about raising the temperatures. Think about what would you think about to get your fingers warmer than they are now. You might think about putting them out in the sunlight. You might think about putting them in warm water. Okay, we wouldn't think about putting them on the stove too much, but maybe on a cooking device. Okay. Is your finger temperature going up? Is it working what you're thinking about? Well, you don't know unless you have a device, and the device is the key to biofeedback. You must have a measuring device showing you that it is working, and that provides you a positive reinforcement, and it provides you a way of learning that this is what works. Okay? So it works by trial and error. It's used to treat measurable physiological functionings like finger temperature and Raynaud's syndrome, hypertension because you can measure blood pressure, muscle tension headaches, we measure the tension in the frontalis muscle, anxiety, we also measure muscle tension. Okay, so these are disorders that can be managed with biofeedback. But most people don't have the patience to learn it works by a system of rewards. Models of depression. Okay. And I mentioned already that depression is a very serious disorder, dangerous disorder because it's associated with suicide. What causes depression? Why will some people become depressed and others won't? We know a little bit about it, but not everything. We do know that people with parents who had depression are more likely to be depressed. There is a genetic component. We also know that if an individual is stressed for a long period of time, they will ultimately become depressed as well. Okay? So it's a combination of biological factors and social factors. And social factors alone can produce depression. Now, in animals, it has always been of interest to develop an animal model of depression so that we can test the drugs on depressed animals rather than on depressed people. Okay? And the model that has been developed is to put an animal, a rat or a mouse, typically in a cage from which it cannot escape because all the escape hatches are closed, and it constantly receives very uncomfortable shocks from the bottom of the cage. So the animal is shocked with the bottom of the cage. So very uncomfortable kinds of experiments to do. I have never done. I've done quite a lot of animal experiments, but never anything like that. I don't think I would have the heart to do that, even to a rat. Okay. But the studies have been done, and what they show is that after the rat is stressed for a while and jumping up and down and running around trying to get out, Eventually, the rat gives up, stops trying to escape. And that is the animal model of depression. That is, the model is that if you try to escape negative situations and find that you are helpless and cannot do it, you learn that it's not going to help you to run around, and you eventually just give up and become depressed. Interestingly, if we take this rat out for the night and give him rest and give him food and give him a comfortable cage, but we put him back in the next day, he lays down on the bottom of the cage. He doesn't even try to escape because he's learned that this situation is inescapable. Okay. Now, if I give him fluoxetine, aka Prozac, if I give him fluoxetine, guess what happens, my friends? What do you think that rat does if I give him fluoxetine? I'm looking for your responses. You think a rat will respond to fluoxetine? He'll try again, that's right. He tries to escape again. He's motivated to escape. Why that is, we do not know. What we do know is that fluoxetine and the other antidepressants increase levels of serotonin and norepinephrine, serotonin in particular for fluoxetine, in the synaptic clefts, in between neurons in the brain. How does that translate into not giving up anymore? That's the part we don't know. And a lot in psychiatry is unknown like that, okay? So he'll try to escape. Now, somebody said that's false hope. Unfortunately, it usually is. But it also tells us that we should make sure that patients have the ability to make decisions for themselves and do not feel like they are trapped in a bad situation. And that's why we give patients patient-controlled analgesia. We don't wait for the patient to be in terrible pain, but they can stop the pain at their discretion, okay? And that will probably help them, and that has helped them become less depressed when they're sick. Okay. Another little graph this graph has been on the boards. That is that a little bit of stress is good for performance. When you have no stress, your performance is not very good. With some stress, your performance improves. Too much stress and your performance goes down again. So when you go into USMLE and start taking the exam with a little bit of stress, you're going to show your best performance. Okay, my friends. Okay. Okay, now we're going to talk about the defense mechanisms, and of course, they were based on the theories and the ideas of Sigmund Freud, who was a Austrian neurologist. He was a neurologist. There were no psychiatrists. He was the first one. Okay. He saw patients who had unexplained symptoms. They were neurological symptoms, but there was no neurological basis, as he could find, for the symptoms. And he noticed that when the patients talked to him, and he spent a lot of time with people, when they talked and talked and talked and talked, eventually their symptoms seemed to remit. He called it the talking cure. And what he noticed about what they said was that they would talk about things that they didn't even consciously remember. But while they were talking, they seemed to bring it up into consciousness. Okay, so that was the talking cure. He developed the idea there of the unconscious mind, that there was something in our minds that caused us to feel unexplained symptoms, depression, anxiety, all of these things. And also what we want to do with our lives. Our decisions are based on this unconscious material, the dynamic unconscious. Later on in his career, he said that the mind had three parts. The id is the part that you're born with. That's your pleasure-seeking, pain-avoiding part. And by the way, these things stay with you throughout life. So you only have an id up until you're 2 years old. And then the ego is developed. Now, the id still stays there. The id is telling you right now to take a nap, go to sleep. The id wants the pleasure of going to sleep, okay? Your ego says to you, your ego deals with external reality. It says, don't go to sleep now because the teacher could say something in the next hour that we're going to need for the USMLE. So the ego controls the id's pleasure seeking. And the ego is present 3 to 5 or 6 years old and throughout life. At about the age of 6, you develop a conscience, a sense of morality, a concern for other people. That's your superego. Empathy, your ability to feel how another person might feel under that circumstance. The superego also controls the id. And the defense mechanisms are the defense mechanisms of the ego, and they help the ego to deal with external reality. So children before the age of 6 do not care how other people feel. Put themselves into his place. They can't do it until they're about 6 years old. Okay? A 6 or 7-year-old should know not to do that to his little brother. If he doesn't know that by the age of 6 or 7, we would have conduct disorder. That is a person with no conscience or support off anxiety. I think general points, they're all unconscious. Patient who, when you denial, which can be helpful for him for the initial stages of getting used to the diagnosis. If he persists in denying that he has lung cancer, it can be critical. He doesn't get treated. Okay. Issue and the issue is intensity and all. Okay, now repression is the basic defense mechanism. We tend to, during our lives, push into our unconscious mind, Freud said this, things that we could not deal with in the real world. They were too uncomfortable. Things like child abuse or sexual abuse in children are repressed, he said, into the unconscious mind. I don't remember it. That's very, very rare that a person doesn't actually remember something, but it does happen, okay? And that is the defense mechanism of repression. It'll never be the right answer on the exam because all defense mechanisms are based on repression. Okay, my friends, let's continue. Here's the most commonly used defense mechanism, denial. This person has his head in the sand. He refuses to believe something. And if he puts his head in the sand, he doesn't see anything, it's not happening. It doesn't really work very well. So denial, I remember you telling me the diagnosis. So, but I know it was a mistake and I don't have cancer. Okay, so the individual knows that this was a mistake. He did hear the news, but he denies that it's true. Okay. A man who has interest in other women than his wife begins to be a man. Okay? He is projecting his own feelings on, believes that she is doing something that he really wants to do. Okay? So I'm sure my wife is cheating on him when he is the one who has those feelings. Little in this world is terrible. They have people who use splitting see people as perfect or terrible. They see situations as wonderful or awful. My high school years were terrible. My college years were fabulous. And of course, there were bad experiences in each of those, but this is the way they see the world. It causes them too much stress to see things as being a little bit good and a little bit bad. So things are either perfect or terrible. That is splitting. It is used often by people with a borderline personality disorder, which we have talked about. Blocking, not remembering something that you know very well. And I always block, for example, on this actor's name, although I know who he is very well. And I saw him for many years on television. But for whatever reason, I block on his name. Why can I not remember his name? I did it again. I just blocked on it, but I just remember on the tip. His name is Tom Selleck. Okay. And I've always thought he was a very handsome man. My husband's name is Tom. I'm going to leave up to you the reason why I don't remember this actor's name. Okay? I'm going to leave that up to you. Okay? Because it makes me uncomfortable. That's right. They're not forgetting it. Freud said you block on it because it makes you about it, that makes you, not because it's insignificant at all, Mohammed, but because it is very significant. Okay? So a patient, for example, may continually forget the name of her disease, and she seems to forget it. Every time she tries to say multiple sclerosis, what is the name of that again? She knows it very well, but she blocks on it because it's uncomfortable. So that's blocking being used as a defense mechanism. Okay, my friends? Good. This is the second most common defense mechanism used by medical patients. That is going back to an earlier stage of development when you are under stress. So this little kid, when his parents get divorced, he begins to wet the bed again. He was all toilet trained, but now he begins with you easily, just like children do. They demand the food that they had when they were little children and they were sick. They want their comfort. We call it comfort food. They don't reach for raw vegetables when they're sick. They reach for something cooked and easy to chew. Okay, just like they did when they were a little child. Okay. Oh, here he's saying if a child starts stuttering. Well, babies don't stutter, so I don't think that that's a really good example of regression. Okay. But talking in a baby-like way. Okay, talking kind of baby talk, the way little kids talk. We know that adults do that when they're under stress, and children do that too. So baby talk, perhaps. Okay? Not so much the stuttering. Okay, sure. Shiri, did you get that? Okay. Crying. Yes, crying for trivial reasons. Children cry when they don't get what they want. Adults know better than to do that. However, when they're sick and they don't get what they want, they cry. So you're not seeing people at their best. You're seeing them at their most regressed when they are sick. This is an important defense mechanism for medicine. Freud described it. He said that people repress their unwanted feelings, and the feelings come out in physical symptoms. Unconsciously, the person converts the stress into a physical symptom. So you know you're going to have an exam next week, let's say. I don't know if you are. I don't know. And before the exam, you get a terrible headache. Every time you have an exam, you get a bad headache. What are you focusing on now rather than fear of the exam? You're focusing on how much your head hurts. So it's a way of getting your thinking processes away from the thing that's really bothering you, which is the exam. And now it's easier somehow, psychologically, to focus on the headache. And that may be the basis of quite a number of unexplained symptoms in patients. That is the defense mechanism of somatization. Unconsciously behaving like somebody you admire or somebody you're afraid of. So this resident ordered to buy a necktie for an affair at school, and he finds himself buying the exact same kind of tie that his attending wears. He's copying the attending. But when everybody sees him at the party, they say, he's doing it just because the attending is doing it. But remember, these defenses are unconscious. He doesn't realize that he's drawn to the tie because he admires his attending. So that is unconscious identification, which is also called introjection. It is a defense mechanism. Okay, this cat is kicking the dog. Okay. Now, cats, because she's so angry and she knows anger. But every time she sees the dog, she just feels like kicking it, and she doesn't. Why? She is displacing her anger at her owner onto the dog. The mechanism is called misplacing. It's kind of misplacing your anger. And it is a very immature kind of defense mechanism. Using your intellectual processes to avoid emotion. This is an example. So this person is describing the skin of a terminal illness. Okay. Description is taking over his fearfulness. He is technically talking about something, and that takes away his fear. Okay. This was a board question. A pilot whose plane is about to crash goes to the back of the plane and talks to the passengers about the technical details of the engine failure. That for? Do you think the passengers care about that? No, but the pilot makes himself feel better by talking about the cows. Okay, my friends. Okay, actualization. This girl has been getting into trouble. She's stealing sunglasses from the store since her brother was diagnosed with cancer. As a way of dealing with that stress. And that defense mechanism reason why he didn't really want them when he really did. We'll have some questions at the end, and we'll see some of these examples. So a rational explanation, I want them. Sometimes a student will say, this has never been before, and everybody knows. You have the same, I'm sure you do. I wish I had time, Wafa, to hear the story and how it's told. Is it a fox in your story? Wafa, is it a fox in your story? No. What is the story about? Where somebody really wants something, can't get it, and says, I don't care. Oh, it's a song. Okay. Okay. Oh, I wish you could sing it for me. Can't hear you. Can't see you. You can only see and hear me, and you wouldn't want me singing. Trust me on that. Okay. Okay, so that is rationalization. It's a song. But the story, the idea is true in many cultures. That is, people opposite way from the way that you really feel. It's unconscious hypocrisy. So this boy says he hates the little girl in front of him, and he's always bothering her. But that's because he really, really likes her. Okay? So he's acting in the opposite way than the way he really feels. Okay? We would see this in somebody who, suppose there is somebody in your life who doesn't like you. Now, everybody has somebody in their life that doesn't like them. Not everybody is loved by all, right? Okay. Come over to you and give you a greeting. Oh, it's so wonderful to see you. Oh, I really missed you. What do you think when you say that person is a hypocrite? Okay, that is, they're acting in exactly the opposite way than they really feel about me. Hypocrisy is reaction formation. People who are hypocrites, they don't, but this Lee is doing that. He is greeting you warmly. He may be even surprised by how friendly he is toward you because he doesn't like you. But he is open, and we call that reaction formation. How are we doing? How are we doing? Good. Okay. For example, in some religions, there is, that is, an individual may do something bad, for example, and then confess it to a clergy person. The clergy person tells them to do certain things, say a certain number of prayers, do something, and the bad thing goes away. It is undone. It is as though it was never done. So somehow magically, it may be through religion, the individual does the bad thing by something they do in the present. And that defense mechanism is undoing. Atonement. An individual who has done something bad to another person tries to do good things in order to get rid of the bad thing that he did to another person. Okay? The defense mechanism is undoing. Okay, my friends. Let's see how we're doing here. This one. Everybody uses dissociation sometimes. When you're under great stress and you feel like you're a little bit out of it. You feel like we call it zoning out in the US. You feel kind of, you're not really here. You're kind of out of yourself, dissociated, not really clear thinking. Freud said that that was a defense mechanism. He called it dissociation. And if you are stressed enough, some people will actually forget something that happened. They will have amnesia for a stressful event. Now, amnesia is almost always caused by a neurological insult, injury. But there is a type of amnesia that is caused by emotional stress, because the individual is using the defense mechanism unconsciously of dissociation. Okay. So there are a whole group of disorders in psychiatry called dissociative disorder, where stress has led to and memory problems. But of course, we always have to rule logical injury first. This is a mature defense mechanism. The next mechanisms, that is, this very overweight man is making jokes about his weight as a way of dealing with as a mature thought is something useful to society. And here I have an example. Jack the Ripper, he was that murderer in England, becomes a surgeon. He channels his urge to cut into people with knives into something that is useful for society. He becomes a surgeon. Another example that they've had on the boards is a man whose child was killed by a teenager who had been drunk. So the kid was drunk and killed this guy's child. That man whose child was killed goes to school and talks to the teenagers once a month about not drinking and driving. So you see, he's using his anger because he must be very, very angry at what happened at teenagers and drinking. But he channels it into a useful... Hey, my friends, where are we now? Altruism. Altruism is a very generous mechanism. People who feel badly about themselves do good things for others, better about themselves. It gives them a better self-image. So here we have a man who works at a soup kitchen. That would be a charity type of place where people who are poor and have no money can come and eat. And we call that a soup kitchen. So he goes and works in the soup kitchen every Saturday, and that makes him feel better about himself. So a lot of charity may be based on altruism. We could say, is all charity based on altruism? Of course, but it certainly helps. People do feel good for others. This is the only partly conscious defense mechanism, suppression. That is, the individual tries not to think about something that's bothering them and is able to enjoy themselves despite having something really negative on their mind, because they push it down into their unconscious mind purposely. Purposely. Do not think about something. So this woman goes to a party, and at the party someone says, "Tell me about your surgery." And she says, "I don't want to think about it now. I want to have fun at the party." So she consciously pushes down the thoughts about her surgery and does have a good time at the party. That is a defense mechanism. Repression. Remember, repression was the first one we talked about? Repression is completely unconscious. You don't even realize that you're pushing it down into your unconscious. In suppression, you do it purposely. You push down thoughts of you as USMLE while I'm talking so that it will not interrupt your ability to learn. If you couldn't suppress that, it would. Suppression is a mature and a useful defense mechanism. Okay, well, let's see. Next time, okay, we're going to start with some questions about the defense mechanisms. So look them over tonight. Do the questions in the notes. Okay, my friends? Okay. Somebody has asked a defense mechanism if all defense mechanisms are unconscious. Hiya, yes. We say with one exception, that suppression is partly conscious. That's right. Khalid had it. That's right. And they are, mostly all of them are unconscious, but suppression has this one bit of consciousness associated with it. All the others are unconscious, I promise.